Institute Rotary Cancer Hospital, AIMS, New Delhi, and Professor Umesh Chandra Singh Yadav, Special Center for Molecular Medicine, JNU, to chair the session. So before I invite them also, I'd like to introduce them a bit. So Professor D.N. Sharma is the head at the Department of Radiation Oncology, and his areas of interest are on breast cancer, gynecological cancer, brachytherapy, bone and soft tissue sarcomas, brain tumors. And Professor Umesh Chand Singh Yadav, he's a professor at Special Center of Molecular Medicine, JNU. His investigation of metabolic disorders and inflammation-induced pathology such as obesity, diabetes, cardiovascular diseases, cancer, and asthma using phytochemicals and advanced technology such as RNA-based approaches. So I request now the honorable chairpersons to take hold of the session.
Okay, thank you, Savio. So welcome everyone to the last day and the last session of this GIAN workshop, which is themed as radiation biology and its clinical application. So at the outset, I thank the organizers, especially Professor Tandon, to invite us to chair the session. And today's speaker, the first speaker is Dr. Maria Souza, who will talk about an overview of clinical application of non-invasive radiological imaging. She will cover radiography, ultrasonography, mammography, CT, and MRI in her talk. A brief introduction about Dr. Maria D'Souza is she is Scientist F and Joint Director and HUD at the Division of NMR Institute of Nuclear Medicine and Allied Sciences, New Delhi. She has done MBBS and MD, and she is member of National Academy of Medical Sciences as well. Her research interest includes onco-imaging, including PET and CT, and MR. Her other area of interest is neuro-oncological imaging, including novel PET radio tracers and novel MR techniques, advanced neuroimaging of traumatic brain injury and ischemic leukotriosis. She has several publications to her credit, and she reviews many important journals, and she has given several presentations, more than 50 presentations at national and international platforms. And her major current activities include clinical imaging and research and teaching the postgraduate students. So I welcome Dr. Maria D'Souza to start her lecture. Thank you.
I'd like to thank you, sir, for that wonderful introduction. And I'd especially like to thank the organizers, especially Professor Vibha Tandon, for extending this invitation to me. So without further ado, I would like to begin. So I'll just share my screen. So as the Honorable Chairperson just mentioned, I'll be talking about an overview of the clinical applications of non-invasive radiological imaging. So what is radiology? Radiology is the science of using medical imaging to help diagnose and in some cases to treat diseases in the human body. And we all know that today radiology has formed one of the cornerstones of medical diagnosis, and medical management of almost any condition relies heavily on a good diagnosis based on the radiological investigations. And we have a huge armamentarium of radiological modalities today, starting with radiography, that is the simple X-ray, to special radiographic investigations like Barium Studies and IVPs, fluoroscopy, which deals with a real-time examination on X-ray, mammography, which is a radiology of the breast, ultrasound, computed tomography, MRI, and interventional radiology. So the question is, why do we need so many investigations in the first place? Now, I'll just take an example. So here we have a young patient who met with a road traffic accident and he had a head injury. Now, when you do conventionally, all we had was an X-ray of the skull. And this X-ray was being used to diagnose whether the patient had sustained any fractures. So you take a look at his X-ray and the X-ray is absolutely normal. But does that mean that the patient is normal? You will find that here, when we do the CT scan, we find here this extra fluid, this collection of blood, which is called the subdural hematoma. And then when we go one step further and you see the MR image, you realize that he has sustained a few these tiny black areas, which are microscopic hemorrhages. So these microhemorrhages are indicative of something called as diffuse axonal injury, which is a very serious condition. So all these modalities, they are complementary to each other and they work in an integrated way in order to arrive at a correct diagnosis. So beginning with a little bit of history. The father of radiology, which is today a much sought after discipline in medicine, was incidentally a physicist. So here we have Willem Conrad Ronjan, who way back in 1895, he discovered X-rays. He was working on an experiment on a cathode ray tube. And during that experiment, he suddenly observed that there was a little bit of green incandescent light falling on a fluoroscopic screen, which was lying nearby. So he wanted to understand more about this particular phenomenon. And so he just darkened his whole cathode tube. He covered it with black paper and he himself sat in a dark room. And then he repeated the experiment. And he was surprised to find that these rays, they actually passed through all that black paper and again produced that green fluorescence on the fluorescent screen. So since he didn't know about the nature of these rays, he called them X-rays. And from then on, it is history. He performed several experiments and he realized that these rays, they don't just pass through glass, but they pass through a variety of structures, including human tissues. And this is the first X-ray which was taken. It happens to be the hand of his own wife, Anna, with their wedding ring. Soon thereafter, when physicists and others came to know that you can actually see through the human body, they started applying this phenomenon for the detection of things like fractures, swallowed foreign bodies, bullet injuries, whether there is any bullet lodged within the body, and so on. And he received the Nobel Prize for this in 1901, and X-rays in the meantime became very popular down the years. Now, what exactly is an X-ray? An X-ray is a form of electromagnetic radiation. So we see here in this electromagnetic radiation, it is this part which is the X-ray spectrum, which has a wavelength of 0.01 to 10 nanometers, and it has a much higher frequency than that of light. So the X-ray spectrum falls between the ultraviolet and the gamma ray spectrum with an energy of 100 electron volts to 100 kilo electron volts. And since these photons are highly energetic, they are able to ionize molecules, produce free radicals, and wreak the damage which an ionizing radiation is able to do. Now, when an X-ray strikes a material, some of it gets absorbed and some of it passes through. And based on this, it can capture an image of the object through which it passes. Now, how do we do that? When you look at visible light, you know that you can see the light, but it cannot pass through objects. In the case of an X-ray, it's the exact converse that's true. The X-ray cannot be seen, it's invisible, but it passes through objects, and this image has to be generated. So originally, the radiographs were made on glass plates, and it was much later in 1918 that George Eastman introduced the film. And today we now have what are called as digital X-rays, the so-called filmless radiology, in which you just capture it onto a screen. Of course, you can take a printout if you want to, and otherwise it remains stored for years or decades digitally. And the advantage of that is that you can manipulate the image, you can zoom it, you can pan it, you could adjust the brightness and the contrast in order to be able to see something better. You can take measurements and so on. So coming to radiography, which is the most conventional form of radiology, I'll be briefly telling you a little bit about the description, the uses, the risks, and the benefits. So radiography is a technique of generating and recording an X-ray pattern for the purpose of providing the user with static images after the termination of the exposure. So what actually happens in radiography is you have a couch here where the patient lies down, or the patient could be erect depending on what you want to see. And this X-ray tube, the beam is passed right through the body. A portion of the X-ray gets absorbed by the body, a portion of it gets scattered, and a portion of it gets transmitted through. And right here, you have a cassette which loads the X-ray film, and you record those transmitted X-rays on the film. Or if you're going for digital radiography, it is just stored digitally. Now coming to conventional radiography. So this is what it looks like. You have a tube here, you position the patient in front of the cassette, and you find the beam, like in this case, the patient is facing the cassette, so the beam of X-ray is passing from the posterior to the anterior, the back to the front of the patient's body. We're taking a chest X-ray here, so this is classically what you call a chest X-ray PAU. Now, once this X-ray traverses this plate, what you have here is a cassette. The X-ray film is loaded within the cassette, and the film is made up of silver halide crystals, predominantly silver bromide, but with a little bit of silver iodide as well. And on either side of this film, lining the cassette is what we call as intensifying screens. So these are phosphorescent materials like calcium tungstate, or rare earth materials like gadolinium, lanthanum, and yttrium. And they help to magnify the amount of effect of the X-ray onto the film, so you can actually get a good image by reducing the X-ray exposure. But this image which is produced on the film, it's a latent image. The silver halide, it undergoes a chemical change when either an X-ray or the light rays strike on it. And this latent image has then to be developed into the final image. So that entire process is called development of an X-ray, which has a sequence of steps, which is classically done in a dark room. And that whole process takes about 30 to 45 minutes. But that was about conventional X-ray, which is now a thing of the past in many, many institutions. Of course, it is still very much there, but no longer so widely practiced. Now coming to the digital X-ray, the most...
Can I intervene, Maria? Is that from somewhere there's a background is coming? Is it from your own?
My room is silent as such, ma'am. There is no sound in my...
Somebody is not muted. Can you, CIS, please mute everybody leaving ma'am? Ma'am and like chairperson, one or two people.
Yes, ma'am.
Please mute everybody. Yeah. Yeah, please, Maria, go on. Okay.
So beginning with computed radiography. Now this is the most basic form of digital radiography. So what we have out here is that you have the same X-ray tube which was used in conventional radiography, but the cassette here is different, and you have a CR cassette, a computed radiography cassette, which contains a photostimulable phosphoplate. So when the X-ray beam strikes this cassette, the energy gets stored in the crystals, the cassette is transferred to what is called as a CR image reader, which scans this plate with a high energy laser beam. And that releases high energy blue light, which is then converted using a photodiode into electrical signals. And then we have an analog to digital converter, which finally digitizes the image and produces what we see as a final image. Now, the advantage of using computed radiography over conventional radiography is, of course, that the whole thing is digital. We go filmless. In addition, we have something called latitude of exposure, which I'll be describing in a subsequent slide. Now, overall, computed radiography has a poorer spatial resolution as compared to normal conventional radiography, but it has a much better contrast resolution. And as a result, the quality of the image on computed radiography is much better. Now, what do I mean by latitude of exposure? Now, in order to take an X-ray, the X-ray technician or the radiographer, he sets certain settings, the kilovoltage and the milliamperes, in order to take it. So if the settings are right, you get a good quality X-ray like this one. If he overexposes, then you get a bad X-ray like this highly darkened X-ray, wherein you cannot really make out any lung pathology. And if on the other hand, he underexposes the X-ray, you get a very light X-ray, wherein again, the details are not clear. Now, in conventional radiography, the moment you do that, you either overexpose or underexpose, you get a bad quality film. So the unfortunate patient has to go for another X-ray, no doubt. But at the same time, the radiographers are very careful to ensure that they are taking good quality X-rays. Whereas in computed radiography, even if the radiographer overexposes or underexposes, you get a reasonably good X-ray. And as a result of that, many times it happens that when the radiographer inadvertently starts overexposing in order to get a good quality X-ray, and the patients unnecessarily suffer from extra radiation. The next type of digital radiography, which is much more popular today, is the proper digital, which is either of the direct type or the indirect type. In a direct digital radiography, the X-rays fall on a photoconductor material, which is generally amorphous selenium. And this X-ray energy is converted into electrical charges, and that is finally read out to produce the final image. Now, in direct digital radiography, you get a very high spatial resolution and an excellent X-ray quality. On the other hand, you have the indirect digital, in which you have the X-rays which fall on a phosphor plate which scintillates, and that light then falls onto a photodiode, which then converts it into electrical energy, and that again through a readout mechanism, either a thin film transistor or a charged coupled device, it can be used to generate the final image. Now, the quality of an indirect is not as good as a direct. It has a lower spatial resolution, but both of them have excellent contrast resolution and are therefore superior to the conventional X-rays. The other thing which a radiographer has to keep in mind when he is taking an X-ray is that he needs to position the patient correctly. If this patient rotates to one side, or if he's not asked to take a deep breath at the time of taking the X-ray, you can get a poor quality X-ray. Similarly, here you have an X-ray of the skull taken for the sinuses, the paranasal sinuses. And if this patient does not angulate his skull properly, or he tends to rotate his skull, you get a poor quality X-ray, and therefore you're liable to come to an erroneous diagnosis. So these are two such examples. You can see the patient has rotated badly. Similarly, on the skull X-ray as well, there is rotation. So one side, the left half of the skull appears to be hazy as compared to the right half, although both sides are actually normal and there's really no pathology on this side. Now, what are the cardinal principles of radiation protection that the radiographer has to keep in mind? So these are the three basic principles which we are all familiar with, of time, distance, and shielding. And that is applicable to the patient, to the staff, as well as to the attendant. So when we talk of time, we should optimize our technique so that it can be done in the least time possible, and you don't have to repeat the X-ray and call the patient again. Distance, we all know, is that as the distance between the X-ray tube and the patient is doubled, the radiation exposure becomes 1/4. That's the inverse square law. And then we have shielding, which is for the X-ray tube itself. We should ensure that the X-ray tube has a proper housing where no stray radiation leaves the tube. The X-ray room, which may be lined with a thin lead sheet, or it may be a thick block of concrete or a layer of bricks. The entire thickness and dimensions would depend upon factors like the workload and the exposure factor and so on. Shielding also for the staff. When he takes the X-ray, he should be standing behind a lead shield, and of course for the patient. Like for instance, if you're taking an X-ray of the skull, you can protect the rest of the body of the patient by covering him with a lead apron. So these are common radiographic practices of using lead aprons. Of course, they're very heavy and uncomfortable. So you can replace it with lead-free aprons like tungsten, antimony, and bismuth. You can increase the X-ray tube and patient distance where it is applicable. You collimate the X-ray beam so that only that part of the body which really needs to be X-rayed is exposed to the beam. Then we have X-ray filters, which filters out the soft X-rays. Otherwise, these soft X-rays, they just go and get absorbed by the patient and they don't really contribute to the final image. And then we have this automatic exposure control, wherein you have a small device which automatically terminates the exposure when the desired amount of radiation is reached. And we have this universal 10-day rule. So when we're taking X-rays of a woman, of a young lady in the reproductive period of life, it is always preferable to take it within the first 10 days of the menstrual period so as to ensure that she is not pregnant. But in any case, it's always important for every radiographer prior to any radiological investigation to find out the last menstrual period and to ensure that there is no pregnancy. Okay, so coming to some of the we now come to the what is called as special investigations. In special investigations, you have these barium studies. Now, what do we mean by special investigations? In this, we generally give a contrast agent to the patient. Now, depending on what it is that we're looking at, it may be an iodinated contrast agent or it could be a barium contrast. Now, in a barium study, you're trying to delineate the gastrointestinal tract of the patient, and it depends on which part of the GIT you're looking at. Like for instance, here we have a barium swallow. In the barium swallow, which you see out here, this is the normal column of barium, whereas here you see that there is a filling defect. And the mucosa of this area is very poorly defined and it is serrated in outline. So this was a carcinoma of the esophagus, which is obstructing the flow of barium lower down, and you see this thin streak of barium coming down. Now, another kind of study is what we call as the barium meal or the barium meal upper GIT, which is used to study the stomach and the duodenum. So here we have the stomach, as well as the duodenum out here. This is the duodenal bulb. This is the C loop of the duodenum, and this is the proximal or the upper part of the jejunum, which has a characteristic feathery pattern. Another case of a barium meal, wherein we find this puddling of barium within the lumen of the stomach, and that is suggestive of an ulcer. So in an ulcer, it will retain the barium, and this is the kind of appearance which you get. And yet another case of a barium meal follow through, wherein you have this part of the intestine is the cecum, and up there is the ascending colon, and this is the terminal ileum. And here you see this narrowing and irregularity, which is suggestive, which is classical of ileocecal tuberculosis. We also have barium enemas, wherein you introduce the barium distally, that is from the anal canal. And we can have single contrast enemas, wherein you can clearly see the rectum, the sigmoid colon, the descending colon, the transverse, and the ascending colon. You also have something called a double contrast barium enema, wherein after you administer the barium, you insufflate air so that you get to see the entire mucosa beautifully if there is any kind of an abnormality in the mucosa anywhere. We then come to another kind of an investigation called hysterosalpingography, in which you want to outline the uterus and the two tubes. So generally this is done in patients with infertility, wherein you want to see whether the uterus is normal in contour, whether there is any block in the tubes, and so on. So you introduce per vaginally the contrast, which is an iodinated contrast. This outlines the lumen of the uterus, which you can see nicely here, and the tubes. And if the tubes are not blocked, then you get to see the spill of contrast into the peritoneal cavity. And then, of course, we have the intravenous spielogram, which is used to study the kidney and the ureters and the bladder, which is also a common special radiographic investigation. We also use radiographic techniques for interventional procedures. Now, what do I mean by interventional radiology? Herein, you catheterize the patient. You may be catheterizing either a blood vessel, which could be an artery. It could be a duct, like the bile duct. It depends on what is the clinical question you have in mind. Now, what you do is, like for instance, this particular case is a coronary angiography. So here we find that after introducing the contrast into the patient's arteries, you find these blockages in the artery. So you can actually intervene and remove that blockage. So the procedure for that is called angioplasty, which is something we're all familiar with. So here we have this guide wire, which is guiding the catheter, which has been introduced into the patient's body, either through the radial artery in the wrist or the femoral artery in the thigh. And that catheter is driven all the way with help of the guide wire to right up till the origin of the coronary arteries, which is at the root of the aorta. And once it's reached here, you can see the narrowing of the coronary artery because of the atherosclerotic plaque. So this is a special kind of catheter called a balloon catheter. And in order to be able to dilate or to improve the flow, we just inflate the balloon so that you can restore the flow to the artery. So this is an example of both diagnostic as well as therapeutic radiology. We come to the next thing, and that is computed tomography. So computed tomography, again, I'll be describing a little bit about overall what is CT about, as well as its uses and its benefits. Okay, so when we come to the description of CT, computed tomography is a non-invasive medical examination or procedure that uses specialized X-ray equipment to produce cross-sectional images of the body. And each cross-sectional image represents a slice of the person being imaged, like the slices in a loaf of bread. Now, this is the CT equipment within our department, and you can use CT for a variety of reasons. I will just tell you how the CT image is produced. So here you have the patient lying down on a couch, and you have an X-ray tube above. But this X-ray tube, unlike in conventional radiography, it tends to rotate around the patient. And as it rotates around the patient himself is moving inside the scanner. So what happens is there are two motions occurring here. The tube rotates around the patient. The table on which the patient lies is moving into the scanner so that this X-ray beam, it traces a spiral path around the patient's body. And as a result, you are able to take X-rays at multiple angles around the patient, and these X-rays are being picked up by a row of detectors. And so you get multiple snapshots of the patient's image, and you can then reconstruct it mathematically using different algorithms. Generally, we use the filtered back projection algorithm, or you might have iterative reconstructions, and then you can generate the final image. Now, the beautiful thing about a CT scan is when the image is being acquired, it is like a cut slice of the patient's body. Like for instance, you are cutting it at this particular level. But you can reconstruct the image in such a way that you're able to visualize the entire structure in all the three planes. Now, conventionally, we call these three planes as the coronal plane, which goes like this, the sagittal plane, which is cutting the body into the right and left halves, and the axial plane, which cuts it into an upper and a lower part. So this is a contrast-enhanced CT scan of the head, of the brain, which is showing you the axial cut in which the image was originally acquired, the coronal section, and the sagittal section. And that's not just for this part, but it is for the entire brain. So in a typical CT scan, you acquire something like 1,000 up to 1,000 images. If you're doing a multiphasic contrast CT, you acquire a huge number of images which you can scroll through to be able to see, to be able to make a diagnosis. Now, there is another concept in CT which is called as windowing. So you can visualize, like this is the CT image of the brain, and you see it in what is called the brain window. When I adjust my window width and my window level, I can see the bone. So this is called the bone window. On the brain window, I can see that there is a mass here, which was actually a large pituitary mass. And on the bone window, I can see that it has destroyed this part of the bone at the base of the skull. And another similar example of a CT of the chest, wherein this is the bone window. You can see the vertebrae, you can see the ribs very well. The lung window, wherein you can see the lung parenchyma extremely well. The mediastinal window, wherein the mediastinal structures, that is the heart and the blood vessels, can be seen extremely well, and so on. Now, some of the applications of a CT scan, we know that in the COVID era, many of us underwent a lot of investigations, and a good number of us must have undergone CT scan as well. So one of the very common and important applications of CT is in chest imaging, because it gives us an exquisite detail pathology within the lung, as well as within the heart and the great vessels. So this is one such typical case of COVID-19, wherein the X-ray does not look very abnormal, but the CT shows this white patches, which are called areas of ground glassing. And very rapidly, we developed a CT score, which could tell us how bad the COVID was. There is another technology within CT, and that is called volume rendering. So what we saw in the previous slide was the base images. These images can then be computationally manipulated in order to highlight different kinds of tissues. Like herein, we have a patient who had a large vascular malformation in his right upper limb. So when I do this volume rendering, I can adjust my transparency to such settings that if I want, I can see his entire skin and the superficial structures, what they look like. If I want to go deeper, I can adjust the settings to see how this influences his underlying muscles. I can go still deeper and see how it's affecting the underlying bony structures. Or if all I want to see is the blood vessels, I can adjust my settings and see it accordingly. Another beauty about a CT scan is that you can manipulate this data in order to get what is called as MIP, maximal intensity projections, and minimal intensity projections. So if I take lung as an example, in an MIP image, what I'm looking at is tissues which appear brightest. So on CT, the tissues which appear brightest are the heart and the blood vessels. So you can see them very clearly. And the other way around, suppose I want to see the airways. The airways appear very dark on CT, and I can then go for the minimal intensity projections and take a good look at all the airways. There is another procedure which is called a CT colonoscopy and bronchoscopy. So the acquisition of this kind of an image is exactly like that of a routine CT scan, but using computer reconstruction algorithms, you can actually place your cursor right into these bowel loops, and you get these kind of images as though you were doing an endoscopic study of the gastrointestinal tract. So here we have the part of the colon, which is showing this abnormality here, and you can try to whiz through the entire colon as though you were doing an actual endoscopy and you visualize the growth within it. And that's not just for the colon, but it can be for any other long lumen within the body, like for instance, the bronchi. So this is a classical CT bronchoscopy. Without introducing any kind of an endoscope into the patient's body, you are able to visualize the trachea. You can see the tracheal rings out here and the two bronchi. And you can pass your cursor right through the bronchi to be able to see whether there is any abnormality, any growth, any foreign body lodged there. We can also perform CT guided biopsies. So when the lesion is very small, it becomes very difficult to place your needle in the right position. And in order to be able to do that, to make sure that your biopsy needle is in the lesion, it's not going into the lung, CT guided biopsies are one of the best modalities available. So the benefits of doing a CT, the amount of information on a CT scan is far greater than on a plain X-ray. And that information is used to diagnose, to plan treatment, and to evaluate a variety of conditions. The detailed images which the CT gives might eliminate the need for an exploratory surgery. So in the past, it was very common to directly go for a surgery for a patient who had a severe abdominal pain or somebody who had a severe trauma, whereas now many of these unnecessary surgeries are being avoided by the use of the CT scan. And of course, it is a very rapid procedure and it's extremely useful in all kinds of emergencies. Now, regarding the risks of CT, there are concerns about the CT scan causing exposure to the patient from ionizing radiation. There are also concerns about a patient having reaction to the contrast agent which may be used in CT. These contrast agents are iodinated drugs, and sometimes a patient might have mild allergies, but occasionally and very unfortunately, a patient might go into anaphylactic shock as well. Now, regarding the radiation issue, globally, the radiation burden from CT is 34% of the total amount of radiation which a person gets due to various radiological investigations. And in the US, we find that 15% of all radiographic studies are CT scans, but it alone accounts for 70% of the radiation burden from imaging. And over the last 20 years, the number of nuclear medicine scans has tripled, but the number of CT scans has increased 20 times. And also the complexity of the scan is on the rise. So now we have something called multi-phasic scans, wherein you do repeated scanning in different phases of contrast administration in order to be able to highlight different properties within the body. And it has been observed that a single population dose of 10 millisieverts could be associated with a lifetime attributable risk of developing solid cancer of up to 1 in 1,000. Now, why is this issue so crucial in pediatric imaging? For one thing, a younger generation has a much higher radiosensitivity, which is 10 times more in children as compared to adults. They have a longer lifetime in which to manifest radiation-related cancer. And there is a lot of pediatric dosing for other drugs such as antibiotics, but very often the dose for CT, the radiation dose, is not traditionally being adjusted. Though of course, today there is that is more of a thing of the past, because now everyone is very conversant about the radiation effects of a CT scan, and the dose is being adjusted to reduce it for the pediatric group. And suppose you use the same CT setting for the adult and for the child having a much smaller body would have a much greater dose of radiation. So we have some inbuilt mechanisms within the CT scanner itself to reduce this radiation dose. And one of these is called as the real-time automatic exposure control. Now, when this X-ray tube is rotating around the patient, then depending upon which part it is passing through, the AEC device automatically restricts the exposure. Like here, for instance, this is at the level of the shoulders, which is a bulky part and so requires a high radiation dose, whereas it decreases in the chest, it's further down in the abdomen, and then it increases in the pelvis. Coming to what is called as CT angiography. In a CT angiography, you are instilling the contrast into the patient's blood vessels, and here we see an aneurysm. This is the normal aorta. You can see the branches of the aorta. You can see the vessels going into the kidney, and you see an aneurysmal dilatation, that is an increase in the lumen of the aorta, which then can rupture and it could be catastrophic. So what you're looking at is a volume rendering image of this aneurysm. And when you look at this transaxial scans, you can see this is the lumen of the aorta, which is opacified with contrast, but around it is this large dark thrombus, which is sitting around it. So CT gives us an idea, not just about the blood vessels, like in a conventional angiography, but also it gives us an extremely good idea about the status of the surrounding tissues. And here we have something more advanced, and that is the CT coronary angiography. So I already showed you about a conventional angiography of the coronary arteries. Now, to do a CT coronary angiography is a challenge because the heart is beating, and any kind of movement can produce distortion of the ultimate image. So we have special techniques in order to reduce that distortion, and we have very fast CT scanners today. And here you can very clearly visualize with the entire coronary vasculature, the right coronary artery, the left, as well as you can see the entire heart shadows, the root of the aorta, and the chambers of the heart. And all this is done with a simple intravenous injection. You do not need to go for that invasive procedure, which I showed you before. But of course, there is one disadvantage that in case you need to intervene, if you actually pick up a block, then the patient has to again go for a conventional angiography to get that blocked artery repaired. The next modality I'll be talking about is ultrasound. Again, a bit about the description, the uses and the benefits. So ultrasound imaging uses high frequency sound waves to view inside the body. Now, the most beautiful part of ultrasound is that it is capturing the images in real time. What happens with a CT or with an X-ray or even with an MRI is that the patient lies in the scanner and he gets exposed to that particular modality. And then you get a series of images, or you get a single image if it's an X-ray, and then you sit down and start analyzing those images. Whereas on ultrasound, the patient is lying down in front of you and you move your device, which is called a transducer, on the patient's body, and you can actually see at that point of time what's going on inside. And the other hefty advantage which ultrasound has is that it does not make use of any ionizing radiation. So you place your transducer directly on the skin or within an orifice, depending on what you're doing. It could be a transrectal ultrasound, it could be a transvaginal ultrasound, and so on. And in order to have a good acoustic coupling between the body and the transducer, you have to apply a jelly on the patient's body. So what exactly is a transducer? An ultrasound transducer converts electrical energy to mechanical energy. Now, this transducer is made up of what is called as piezoelectric crystals, which are typically lead zirconate titanate material. Now, these crystals have a series of dipoles. They're very thin crystals, but they have dipoles within them, which are arranged in a geometric manner, with electrodes on either side of the crystal, so that when you rapidly change the voltage between the electrodes, the dipoles move and the crystals rapidly changes its shape, and that produces a rapid vibration which generates ultrasound waves. Now, as the name itself implies, ultrasound means it is having a much higher frequency than conventional sound waves. So sound waves have a frequency of between 20 and 20,000 hertz. When it comes to an ultrasound, the frequency we use is between 2 to 12 megahertz. And just like sound waves, this also undergoes reflection, refraction, and absorption, depending on the acoustic properties of the tissue through which it passes. And finally, once it strikes the tissue, it gets reflected back, and those reflected waves are again picked up by the transducer, by the crystal, and the crystal gets compressed, and again a voltage is generated, which is then that electrical signal is sent to an ADC, an analog to digital converter, in order to produce the final image. So some of the uses of ultrasound: one is an abdominal ultrasound to visualize the various tissues, breast ultrasound, fetal ultrasound, Doppler fetal heart rate monitors to listen to the fetal heartbeat. And we have Doppler ultrasound itself, which would visualize blood flow through various organs, echocardiogram to view the heart, and ophthalmic ultrasound to visualize the eye structures, musculoskeletal ultrasound, an intracranial ultrasound, and ultrasound guided needle placement, whether it be for a biopsy or for a drainage of an abscess or so on. So this is the typical image of a fetal ultrasound, which almost every woman at some point of time during her antenatal checkups has to undergo. And now we have something called as three-dimensional ultrasound, which gives us a 3D picture of the fetal body. And now we also have 4D ultrasound, wherein you can see this in real time as you move your transducer on the patient's body. We have something called transcranial ultrasound as well. Now, generally, ultrasound rays do not pass through the skull. The skull is an impediment to ultrasound imaging. But in the case of a very young baby, a newborn baby, we have these two windows, the fontanelles. This is the anterior fontanelle, this is the posterior fontanelle. So you place your probe on this fontanelle, which is free of bone, and you can nicely visualize the brain. So while the baby is in the NICU, the neonatal ICU, you don't have to shift him anywhere. You can use this ultrasound device and check out if he has any complications, like in this baby who has hydrocephalus and has also developed an intracranial hemorrhage. The other applications, one common application is to be able to see the gallbladder, and here you can nicely see the gallstone, which is casting a shadow on the image. You also have ocular ultrasound. You can see here the eyeball with a foreign body within it. You can also do an ultrasound guided biopsy or a drainage. So here is the probe and there is a biopsy needle attached to it, and you can visualize the needle which is passing right through the liver in order to take a biopsy of this lesion. And liver abscesses used to be very common in the past. They are still common today in some parts of our society. And you can use the ultrasound to guide the drainage of the abscess by inserting the needle and withdrawing the pus. Now, the benefits of ultrasound. Ultrasound is based on non-ionizing radiation, so it does not have the risk which an X-ray has. It is generally considered to be a safe investigation, but it can produce a little bit of heating of the tissues. And it can also produce some pockets of gas, which is called as cavitation within body fluids. But this is more of an exception rather than the rule. And overall, ultrasound has been considered to be a very safe modality, although of course, the long-term consequences are still unknown. We have something called Doppler ultrasound. In a Doppler ultrasound, it makes use of the Doppler effect. The Doppler effect is the shift in observed frequencies of waves from moving sources. So here you see a blood vessel. This is the superficial femoral artery. And using Doppler, you can make out whether there is a flow is present or absent. Is the artery blocked or is it patent? What is the direction of flow, the velocity of flow, and the type of flow? So the arteries, they are high resistance blood vessels, so the flow is always pulsatile. That is to say, it has a rapid upstroke during the systole, a flow reversal in diastole, and again a late forward flow in late diastole. So depending on what vessel you're looking at, the flow pattern is also very different. Like here you have a muscular artery of the leg called the posterior tibial artery, and you see this characteristic triphasic pattern. You have something called the internal carotid artery, where you see a low resistance arterial flow pattern. And when it comes to venous flow, flow in the veins, it does not have this pulsatile pattern. It's just a low velocity continuous flow pattern. Again, when we talk about, let's say, for instance, the cerebrovascular system, I will just explain this diagram to you. This is the aorta, and you have these important blood vessels which go to the brain. So depending on what is the vessel, whether it's the internal carotid or the external carotid or the common carotid artery or the vertebral artery, they all have characteristic signatures, Doppler signatures, depending on the flow. For instance, the internal carotid artery supplies the brain. So it's a low flow system wherein you find that the peak is blunted and you have a good deal of diastolic flow. Whereas the external carotid artery, this is the external carotid artery, which supplies the structures of the face and the neck. It doesn't really go to the brain. So it has a high resistance flow, you can see the sharp peak out here, and you can see the very low flow in diastole. So all these flow patterns get disturbed and distorted depending on the pathology which is underlying. We have color Doppler, wherein maybe you're not interested really in knowing the flow velocity or the flow pattern. You just want to know the overall vascularity of a particular pathology. So here you have a lesion which is highly vascular and it produces a lot of flow as compared to the normal uninvolved part of the body. Similarly, you have an acute appendicitis. Because of inflammation, there is a very high flow, which you can see on Doppler. We then come to MRI. Now, MRI, again, that is magnetic resonance imaging, it makes use of non-ionizing radiation in order to create useful diagnostic images. So in simple terms, an MRI scanner would be consisting of a large, powerful magnet. There is a magnet in here in which the patient lies. And we have radio frequency signals which strike the body and the receiver radio frequency signals which are receiving the emitted signals from the body. And this is what is ultimately converted into an image. Now, when we look at the strength of a magnet, what typically we are using is something like anywhere between 0.2 to 3 Tesla magnets in MRI, and that's 60,000 times stronger than the magnetic field of the Earth. Of course, now we have, under research applications mostly, we have 7 Tesla magnets and 9.4 Tesla magnets, and 10.5 Tesla magnet has recently been introduced. But for all practical purposes, including at our own center, we are using a 3 Tesla magnet, which gives a very good resolution. So the underlying principle, when you look at it, we have water molecules throughout the body. And these water molecules are basically protons, which have they contain hydrogen nuclei, which are protons, which have a positive charge. And these molecules are in constant motion, so they have a positive charge, and they're also spinning. They have a charge and a spin. And we know that anything which has a net charge and a net spin, it will be acting like a small dipole. So we have tiny magnetic dipoles within our body, and when you place this body within a strong magnetic field, all these dipoles will align themselves parallel or anti-parallel to the field. And then you apply your radio frequency pulse, it will give a very strong energy to these dipoles. And that is the principle of resonance, that you give a radio frequency pulse which matches the precession frequency of these protons. So why we use proton MRI? Most of the times you must have heard of this word, proton NMR, because protons are the most widely used, they are most abundantly present in the human body, and their solitary proton gives a very large magnetic moment. But you can have several other kinds of MR active nuclei, which have an odd number of protons within the nucleus. For instance, you can have sodium 23, fluorine 19, phosphorus 31, carbon 13, and so on. So what are the uses of an MRI? It is used to detect anomalies of the brain and spinal cord, for tumors, cysts, and other anomalies in various parts of the body, breast cancer screening in women who face a high risk of breast cancer, injuries or abnormalities of the joints and bones, such as the back and knee, cardiovascular pathologies like cardiomyopathies and congenital heart diseases, diseases of the liver and other abdominal organs, and the evaluation of pelvic pathology. Okay, now the benefits of MRI. The advantage of an MRI is that you can image without making use of ionizing X-rays. You can acquire the image in multiple planes, axial, sagittal, coronal, or oblique, without having to make the patient get up and lie down in that plane. So that helps you to come to a more accurate diagnosis. MRI images demonstrate a superior soft tissue contrast as compared to CT scans. So it gives you an excellent soft tissue resolution, and it is very good for the imaging of brain, spine, joints, and other soft tissue body parts. You can generate angiographic images on an MRI even without the use of contrast material. Then you have certain advanced MRI techniques like diffusion, spectroscopy, and perfusion. And you have functional techniques like functional MRI, which will tell you about the activity in various parts of the brain. And you can do all this within one study, so you can assess multiple parameters within a single MRI study. Now, what are the risks of an MRI? MRI uses powerful magnets, so any metallic thing within the body can be a hazard for the patient. So anybody who has any of these devices which are non-MR compatible is not allowed to enter into the MR scanner. Of course, today we have MR compatible devices which are made up of titanium, but the ones who had undergone surgeries in the past, they would all be having devices made of stainless steel or other metals which are not suitable for MR. Coming to an MRI of the brain, the other problem with an MR is what is called as claustrophobia. Now, very often we find that the patient has to enter into this long tunnel, and he may find it very uncomfortable and may not be able to lie down. And especially if he needs to undergo something like a head scan, he also additionally has to lie down within this contraption, which contains the radiofrequency coils, and so he may feel claustrophobic and may not be able to get the scan. But the final image which you get shows an excellent resolution. You can see the different parts of the gray matter, the white matter, the ventricles, the basal ganglia, and so on. So a word about brain and spinal cord imaging. You can detect conditions like cysts and tumors, diagnose damage to the brain caused by injury or stroke, diagnose the cause of seizures, diagnose infectious or autoimmune diseases like encephalitis and encephalopathy, evaluate problems like persistent headaches, dizziness, weakness, detect chronic demyelinating disorders like multiple sclerosis, assess the cause of developmental delay in children, identify and evaluate degenerated or herniated spinal discs, evaluate the bones of the spine for congenital or acquired abnormalities, and determine spinal cord anomalies. So a typical MRI of the spine, here you see the vertebrae which are appearing normal, and you see the spinal cord passing through the spinal canal. But at this level, you see this intervertebral disc which is bulging out. It has prolapsed behind and it is pressing on the nerve roots. An MRI of the brain here. This is the sagittal section of the brain. You see here the cerebrum, and here is the cerebellum. But what you see here is the cerebellum is herniating down through the foramen magnum. And this is a classic case of what we call as Arnold-Chiari malformation, which is a congenital anomaly. Coming to MRI of the abdomen and pelvis, this is being used to diagnose causes of pain, including appendicitis, evaluating injuries, diagnosing infectious diseases, delineating cancers, monitoring the response to cancer treatment, diagnosing pelvic pathology, assessing fistulas in ano, and assessing biliary and pancreatic pathology. So here we have an MRI of the abdomen, two different MRIs. One is showing what we call an MRCP, magnetic resonance cholangiopancreatography, wherein you can see the gallbladder and you can also see the bile ducts. So there are times when you may not be able to pick up gallbladder pathology on ultrasound, or you need some more information, and you go for this MRCP. So here you can see tiny stones, calculi, within the gallbladder lumen, which are appearing dark, and additionally, something which was not seen on the ultrasound, that is tiny calculi within the common bile duct. Another patient, this is an MRI of the pelvis. This is what a normal female pelvis looks like. You have the bladder in front, the urinary bladder is well visualized out here, and you have the uterus behind it and the cervix. And within the uterus lies the endometrial cavity. So here you see this part of the uterus appears fine. You see the endometrial cavity out here, but you see this large growth which is arising from the cervix, and it has invaded into the uterus as well as into the adjacent parametrium and going behind and impinging on the rectum as well. So that was a case of cervical cancer. Coming to MRI of the joints and bones, so it can be used to diagnose sports-related injuries, both in the bone and in the soft tissue, detect the presence and extent of tumor, of infection, as well as to diagnose developmental joint anomalies in children, assess joint pathologies, inspect the marrow for leukemia and other diseases, and examine complex fractures. So this is a normal MRI of the knee, and here you see an MRI which shows you a lesion within the bone. This was an osteosarcoma arising from the bone. Coming to MRI of the heart and blood vessels, you can use it to evaluate the structure of the heart and the blood vessels, find the cause of arrhythmias, that is abnormal heart rhythm, evaluate infections, evaluate perfusion or blood flow to the heart muscle, see the findings after doing surgery. You can even see the coronary arteries using an MR coronary angiography. And when a patient has had a myocardial infarction, you need to know how much is the dead tissue and how much of it can be saved. And that can be done using an MRI. So this is one of the classical MRIs of the heart. You can see the different chambers, the right atrium, left ventricle, the right ventricle. This is another axial cut of the same. You can see the different chambers. You see the right atrium is appearing enlarged in this patient with pulmonary arterial hypertension. You also see this angiography. This is the MR carotid angiography, which shows you the carotid arteries, how they enter into the brain, and they bifurcate and supply the entire brain. Now, is MRI safe in pregnancy? MRI can be performed in pregnancy. It is very safe in the 3rd trimester as well as in the 2nd trimester of pregnancy. Now, when it comes to the 1st trimester, that's the first 3 months, we are not very sure. So it is not advisable to go for a fetal MRI at that time. But later in pregnancy, if the fetus is having some congenital malformations which are not properly accessible on ultrasound, one can go for an MRI and assess these in great detail. Breast MR is another important upcoming area. In patients who are at high risk of developing breast cancer, it will help you to detect the cancer. Multifocal cancers such as this, which are unsuspected, can be picked up. It's also used as a problem-solving modality. Generally, in a breast cancer, you go for a mammography and an ultrasound, and of course, you go for a biopsy. But if there is a mismatch between these different modalities, you go for an MRI, and also you can use it to detect recurrences. And also, in a person with an implant, it becomes very difficult to assess any kind of pathology, both on the mammography and on the ultrasound. And here, MRI becomes a very useful technique. We have other important advanced techniques on MRI, like diffusion weighted MR. which makes use of the diffusion of water molecules within the brain. So this is a normal MRI scan, but the person was suspected of having stroke. So he went for this diffusion weighted MRI, and you find here this ischemic tissue. So when it comes to stroke, time is brain. You need to intervene very much in time within the first few hours, and this particular technique becomes indispensable to come to a correct diagnosis. We have diffusion tensor imaging, which will tell you about the diffusion along the long tracts, like the long spinal cord or the white matter tracts of the brain. So here we had a patient of spinal cord injury. You can see the vertebrae are destroyed. What is the condition of the spinal cord? So you can see very well how these fibers are torn through using this technique called DTI. And this is DTI of the brain, which shows you the corpus callosum, the internal capsule, and the different white matter tracts within the brain. We can also do a brain morphometry. We can assess the gray matter volume, the white matter volume, the cortical thickness, the cortical surface area, and many other parameters using morphometric assessment on MRI. Then we have what is called as functional MRI, wherein you make the patient perform a particular function, and that part of the brain, it shows increased activation. So that those images can then be subjected to complex post-processing in order to be able to detect the normal from the abnormal. Like in this case, the patient was given a visual stimulus, and we know that it's the visual cortex which lies in the occipital lobe which gets activated. So you can see this activation pattern within the occipital lobe. MR can also be used for spectroscopic evaluation, like in the breast or in the brain. Now, in the breast, for instance, there are high lipid peaks which come, whereas if you get a high choline peak, that is a marker of an active tumor. Similarly, in prostate, MR of the prostate, citrate is the normal biochemical which is very seen in very high concentrations in a normal prostate. Whereas in a prostatic cancer, you get to see a choline peak which is very high and again clinches the diagnosis of a malignancy. So just to conclude, we have a whole gamut of radiological investigations, right from the humble X-ray down to MRI. And a lot of these investigations are within affordable reach of a lot of people. But along with these investigations, there might be a risk of exposing the patient to radiation. Now, is that risk warranted? Does the benefit outweigh the risk? That's a decision which each of us needs to take in an individual case. And it's important for us to image gently and image wisely, ensuring the optimal utilization of every diagnostic modality to come to a correct diagnosis, but not overuse these modalities just because they are available to us. Thank you.
Thank you, Dr. D'Souza, for very enlightening lecture. And in your lecture, you have covered most of the radiological based imaging techniques for the diagnosis as well as intervention wherever it is needed. I hope that the students must have been benefited as it was very exhaustive and very enlightening lecture. I invite if they have some questions, so we can look into this chat box. So Andra has asked if a person has to undergo a chest X-ray repeatedly after small intervals, what are the possible adverse effects?
Okay. So when a person is subjected to a chest X-ray, the amount of radiation which he receives is only 0.02 millisieverts. Now, the amount of radiation which each of us annually gets from natural sources, be it cosmic radiation or anything, is something like 2 to 3.5 millisieverts. So the amount of X-ray radiation is actually very negligible, and one can go for a series of X-rays if it is needed. It will not produce any kind of damage or any adverse effect. But it's also important to know that anytime in a person's lifetime, we do not know how much more radiation he might be subjected to in his lifetime. So just doing an X-ray just for the sake of it, that you have this facility with you, or the doctor is not very sure, just going randomly for a series of X-rays is not advisable. If the X-ray is really mandatory, if it's going to help in the management of the patient, then by all means, one can do a series of X-rays because the radiation incurred is very less.
Yeah, so related with this, there was advisory during second wave of COVID. A lot of people were getting done HRCT for their lung, and I think doctors suggested that don't get it done unnecessarily under, unless doctor advises it. So that was probably associated with the risk that it carries. So can you, just let us know, the student also, how X-ray of the lung and the CT scan of the lung differ in terms of the risk that they carry?
Yeah. So in an X-ray, as I just mentioned just now, that the amount of radiation you get is something like 0.02 millisieverts, that's all. When you do a conventional CT of the chest, the amount of radiation would be typically between 8 to 10 millisieverts, which is much, much more than just taking one X-ray. But having said that, the amount of information which you get on that CT is also much more than what you get on the X-ray. So it is for the clinician to decide, should I be subjecting my patient to that much of radiation exposure? Will my management of the patient be different, provided I gain a particular amount of information? And if the answer to that is yes, then he should go ahead for the CT, otherwise just restrict only to the X-ray.
Right. There is a question that is from Andhra again. Could you please elaborate on citrate-based prostate cancer diagnosis? Why are you using citrate in this?
Okay, so we are not doing a citrate-based prostate cancer diagnosis. What we are actually doing here is, when you have a normal prostate tissue, you have a high amount of citrate within that tissue. It's just like when you're doing a brain scan and a spectroscopic study of the brain, you have a very high level of a chemical called N-acetyl aspartate. When you're doing a breast scan, you have a very high level of a chemical called lipids. You have a high level of lipids. But when you're dealing with a cancer within these tissues, there is a very high membrane turnover. And so there is a very high level of choline, be it a brain, breast, prostate, or any other kind of cancer. So when you see that choline peak, which you do not normally get to see in a routine MR of the prostate. Now, this is a healthy tissue. You see a very small choline peak, whereas when you see the cancerous tissue, you see a very high choline peak, which tells you that this suspicious looking tissue is cancerous. Many times it happens when you're doing an MRI of the prostate, you may not really be able to distinguish the normal from the abnormal. So we have multiple parameters which we are looking at. One is the MR spectroscopy, the other is MR perfusion, the other is diffusion weighted MR, and so on. And we find spectroscopy to be very useful to be able to diagnose a cancer from a normal or a hyperplastic prostatic tissue.
Okay. Next is from Chetan. What is your opinion on newer techniques like photoacoustic or optoacoustic tomography and its relevance in the clinic?
So as far as the clinics are concerned, I'm a clinician and I deal only with the modalities which are being used in the clinics. So we have no experience with photoacoustic imaging, and so I would not like to comment on that. I've just restricted my talk to radiological modalities which are being clinically used in various hospitals.
Another is from Dr. Amandeep. Please discuss about the least advisable radio imaging method, but required to be performed as no alternative available to that.
I couldn't understand the question.
Yeah. So he's saying that is there any radio imaging which is least advisable? People are, no, usually do not advise it, but it is required because there is no other alternative. So maybe HRCT, as you can see during COVID, it was least advisable because of the risk involved, but in some patient, because there is no other alternative to have that much greater detail of the pathology, you can understand from that.
Yes, yes. I think that probably explains this question altogether.
Yeah. So, ma'am, I actually wanted to understand. I have one question from my side. So we have CT angiography, and you also discussed that MRI could also be used for same purpose. But what is the difference? Can we differentiate the two in terms of identifying the blockage in the coronary arteries?
Yeah. So when it comes, so there are two types of angiographies. One is the coronary angio and the other is the non-coronary. Now, when it comes to coronary angio, it's a little different from all other kinds because those blood vessels are lying on the surface of the heart and the heart is beating continuously. Any kind of movement becomes an impediment to producing a good image. So you need a modality which is very, very quick. And the maximum speed in terms of modality wise we have been able to get is in CT scans, wherein using a dual source CT, just within one heartbeat, you can actually acquire that entire information needed to produce a coronary angiographic image. So that is why if there is a choice between a CT and an MR, it would be better to go for a CT coronary angio. But when it comes to other kinds of angios, whether it be a carotid angiography or it be in the abdomen, maybe a renal or an aortic angiography, both the modalities are extremely good. Now, both of them are a little complex. They require a little amount of technical expertise to be able to do it and to post-process the images which are generated. So I think there is a lot of center-to-center preferences. There are some centers where they would prefer to go for a CT angio directly. Some would prefer to go for an MR angio, let's say for a carotid vascular obstruction. But both of them are quite equivocal and they give a good amount of information. The other thing is that when we're dealing with a patient who is having a kidney issue, he's in renal failure. In that case, you cannot give him contrast on CT scan. CT scan makes use of iodinated contrasts, which are potentially nephrotoxic, and you cannot do an angiography on CT without contrast. Whereas on MRI, we have both contrast-enhanced MRI angios and we have non-contrast MR angios. And if the patient should not be given contrast, go directly for an MRI and do the scan without giving contrast. So you save the kidney and you also get the adequate information.
Yeah, that is understandable. Thank you for your answer. Palak is asking, what do you mean by radiation burden? And is there a specific reason for using lead apron or lead-free apron? What is the reason of still using CT if MRI can be used?
Okay. So she has asked many questions in one question.
Yeah.
Starting with this, why do we use lead aprons and lead-free aprons? So as such, we don't always use the lead apron when we're taking a routine X-ray. The radiographer simply stands behind a red shield, behind a lead shield. But we have this technique called fluoroscopy, in which the person is going on seeing the images as they are being generated. Like for instance, you are wanting to pass a nail through a broken bone in the OT. Now in the OT, you have to make sure that the nail which you're using to repair the broken bone is passing right through the fractured fragments and in the correct way. So you need to take X-rays continuously, which is called fluoroscopy. Now the person who is taking those X-rays will be exposed to radiation, And in order to safeguard him, he should wear a lead apron, if possible, a thyroid shield, and so on. So generally, lead aprons are worn by staff in order to protect themselves. And also, they may be worn by an attendant who should be there within that particular center when the procedure is being done. Now, normally what happens when you're undergoing a CT scan, you make the patient get inside the scanner, you all move out of the room, there is a lead glass through which you can visualize the patient and you acquire the scan. But if the patient is very serious, if the patient is a child, if the patient is very anxious, you need to place the attendant also next to the patient within the room. So you make the patient's relative attendant wear the lead apron. Now, a lead, as I told you before, it is very heavy. If you ever tried out a lead apron, it becomes very uncomfortable to wear it for long periods. And there are doctors, radiologists, cardiologists, orthopedicians who may have to do this surgery or the procedure for several hours. And so you try to give them something more comfortable. And that is those lead-free aprons, which also protect you from the X-rays, and they are lighter. Now, the next question which you asked is about if MR is available, why go for CT at all? Now, that's a very good question. But the whole thing about these modalities is that they're all very costly, and MR is much costlier than CT. Also, the availability of an MR is much less than that of CT. You will find many more CT centers and not that many MR centers, especially in remote parts of the country. There's hardly any MR center. The third thing is, as an investigation, an MR is much more time consuming than a CT scan. So for logistical considerations, people generally prefer to go for a CT scan.
Yeah.
Of course, it depends from center to center. There are centers wherein they just keep doing MR scans day and night, and but as a general rule, CT is performed in much larger numbers than MR.
Yeah, I think we should end, but there is a last question we can take, and we because I think second lecture is also yours only. So you have been already speaking for 2 hours continuously. So probably we need some 5-minute break before we resume the second session. The last question, Amandeep is reading. Dr. Amandeep, please explain about single barium enema and double. What is the dose in these methods? And what is the time of clearance from body?
Okay, so when it comes to a single contrast barium enema, it's a very simple technique. You make the patient lie down and you pass an enema tube inside and you give barium, generally 25% weight by volume of barium. The dose depends on, the radiation dose would depend on how many X-rays you're taking of the patient while doing the scan. What is the duration of the entire procedure? If while doing the scan, you find that everything looks normal, you do not tend to spend too much time with the patient. But if you find that there is some abnormality which needs further assessment, you automatically take longer period of time to do that fluoroscopy, and so the radiation dose is higher. So there is no one figure which can tell you, okay, this is how much of radiation dose a patient will get when I do the barium enema for him. The second thing is between a single and a double contrast barium enema. In a double contrast, after instilling the barium into the patient's bowel, if you remember the images which I showed you, in the single contrast, the whole thing appears white, whereas in the double contrast, you have now insufflated air inside. The moment you do that, you're actually having a contrast between the lumen, which is filled with air, as well as the surrounding barium, which is lining the mucosa.
I think that was of the intestine. Yeah, this one.
Yes, this one. This was a single contrast. The whole thing is appearing white. So I can make out if there is a big mass here, which is going to narrow the lumen, destroying this part of the intestine. I can make it out very well. But on the double contrast, I'm able to see the mucosal outline. If you look at the wall of the bowel loop, it is appearing so clear and so crisp and so beautiful. If there is some small defect, some abnormality in the mucosa at this point, you can make it out on a double contrast barium. You may not make it out on the single. So double generally gives much more information than a single, but it's a little uncomfortable for the patient because in addition to instilling barium, you're also instilling air, and he gets that feeling of fullness, which makes him uncomfortable. So I hope that answers the question.
Yeah, thank you, ma'am. Thank you very much for also addressing the questions asked by the participants. I see that next lecture is also by you only. So would you like to have break or would you like to continue?
I'll just take a 5 minutes break and then.
Yes, I think that is aptly done. Yeah. So, so we can have a 5 minutes break and maybe we can resume at 11:45. That will be nice.
Yeah, good. Thank you.
Ma'am, Dr. Sharma he has joined? Professor
No, I
Sharma?
don't see him.
Okay.
I don't see him.
Yeah. So we'll have break and we'll resume at 11:45.
Okay.
Thank you.
Thank you.
Thank you.
Should we restart the session, ma'am?
Yeah,
Sure.
I think participants are there. I mean, during the break also, they kept logged in.
Yeah.
So, yeah, so we can start second lecture today. That is lecture number 16, which is again by Dr. Maria Souza. We have already seen her one lecture, which was very informative. Second lecture topic she's going to present today is clinical applications of hybrid imaging, PET-CT and PET-MRI. So because we know the now background of these techniques, we can see their clinical application and hybrid imaging she will be discussing today. So you can start.
Okay. Thank you, sir. So I'll be talking about PET-CT and PET-MRI as our chairperson has just informed us. Now, when we look at the imaging modalities we have today, we have two kinds of modalities. One is the structural imaging, which tells you about the body structure like CT, MRI, ultrasound, X-ray, mammography, and so on. And we have functional or molecular imaging, which tells you about the functioning of various parts of the body right down to the molecular level. And you have PET, that is positron emission tomography, SPECT, single photon emission computed tomography, optical imaging, functional MRI, and so on. Now, if you're just going to assess the structure of the body without the function, it is like assessing a corpse. And if you're going to look only at the function without assessing the structure, it's like looking at a ghost. So the ideal way to go about it is to assess the structure and the function together. And that is why we have this hybrid imaging, wherein you merge two different modalities like CT or MRI with SPECT, PET, or optical imaging. And of these, PET-CT has been the most popular, followed by PET-MR. Now, what exactly is a PET-CT scan? A PET-CT is a multi-modality technology which allows the correlation of findings from two concurrent imaging modalities in a comprehensive examination. So there is a fusion of anatomical information from CT with metabolic information from PET. So this is what a PET-CT scanner looks like. You have a PET scanner, you have a CT scanner, and you have a patient table. So the patient moves inside, he gets a CT scan done first, and then immediately after that, he undergoes a PET scan. In a typical PET-CT center, you have a cyclotron which produces the radioisotope. So we know that you bombard the charged particles, be it protons or neutrons. And like for instance, if you're going to synthesize Fdg, you need fluorine-18 as your radioisotope. So you bombard the protons with oxygen-18 enriched water, and you get this fluorine-18 radioisotope, which is then subjected to suitable radiochemistry, and you get your radioligand. For instance, we use manostriflate in order to synthesize Fdg, fluorodeoxyglucose, which is a positron emitter, and you then inject it into the patient's body. It gets distributed within the body, which may take several minutes to an hour, and then you make him undergo the scan, and then you assess the image. So when you're injecting a positron emitting radioisotope, it releases positrons. The positron combines immediately with an electron, which forms an unstable positronium, which spontaneously annihilates into two photons, each with an energy of 511 kiloelectron volts. And these photons are traveling coincidentally in time, but in opposite directions, and they go and strike a series of detectors placed around the patient, and that image is then reconstructed. That data is reconstructed to produce the final image. So the beauty of PET is that you can assess molecules right down to the picomolar concentrations, whereas on CT it's at the millimolar and on MR it's at the submillimolar level. Now, PET has wide applications, but 85% of PET studies are performed in the field of oncology, 10% in neurology, and 5% for cardiological applications. Now, the most common tracers which are being used for PET imaging are fluorine-18 with a half-life of 110 minutes, carbon-11 with a half-life of 20 minutes, nitrogen-13 with a half-life of 10 minutes, and oxygen-15 with a half-life of just 2 minutes. Now, other than these, we also have other tracers which are produced from solid targets, like you have scandium-44, copper-64, zirconium-89, iodine-124, and so on. But most PET centers produce these 4 radioisotopes. Now, the PET studies at NMAS, we have been fortunate to be having a cyclotron, which is under the leadership of Dr. Anil Mishra, which has synthesized a huge number of radiopharmaceuticals for the first time in Southeast Asia. Of course, we have this Fdg, which is being used for glucose metabolism, which is being used all over the world. But we also have other tracers for amino acid metabolism, lipid metabolism, DNA synthesis, hypoxia, neurotransmitters, hormone receptors, and somatostatin receptors. And this is the PET-CT center at our institution where all these studies were performed. Now, coming to FDG, fluorodeoxyglucose is aptly called the molecule of the millennium because there has been no other molecule which has had such a wide-ranging effect on the lives of people, patients, and their families. So how does FDG work? Now, we know that when glucose enters into the cell, it is acted upon by hexokinase and it's phosphorylated into glucose 6-phosphate, which undergoes further metabolism. Now, when it comes to fluorodeoxyglucose, there is an upregulation of this hexokinase in tumor cells. There is also an increased influx of glucose within the tumor cells because of an upregulation of the GLUT transporter proteins. But once it's phosphorylated, it remains trapped within the cell. It does not undergo further metabolism. Now, what does a normal PET-CT scan look like? So here you have, So you have here a simple PET image, and you have a CT image, and then you have a fused PET-CT image. So whenever we perform a PET-CT, we are confronted with a series of images. It may be in the axial plane, and we can transform it into the sagittal and coronal planes, and you get to see the CT, the PET, the fused image, and the MIP image, which gives you an overall idea of distribution of the radiopharmaceutical within the patient's body. Now, what exactly is the role of CT in PET? Just for your information, PET as a modality, it was introduced to the world in the year 1972. And it was in 1998 that the concept of PET-CT first emerged. And by 2001, the first commercial PET-CT scanner had been introduced into the market. But within just 5 years, that is by 2006, PET-CT was found to be so useful that it completely phased out the standalone PET. And so today, we do not have standalone PET anymore, excepting maybe for some research applications. So looking at the role of CT. Now, when you have a pure PET image, you have an image like this. The radiopharmaceutical has been injected into the patient's body, and it starts releasing positrons, and the gamma rays are then picked up by the detectors. But as these gamma ray photons pass deeper and deeper into the patient's body, they progressively get absorbed and scattered, and therefore they get attenuated. As a result of which, you find that the activity on the surface of the body is very high, whereas the activity deeper inside becomes very low. So you are at risk of missing out pathology in the deeper seated tissues as well as in the superficial tissues. So you need to correct for these attenuation changes, and that is where CT comes into play. We know that the image which is produced on CT is nothing but an attenuation map of the X-ray photons as they pass through the patient's body. So you use that data for attenuation correction, and you get these beautiful, clear images on a PET CT scanner, as opposed to these kind of images on a pure PET scanner. Now, in addition to that, CT, as I told you, gives a good idea about the anatomy of the tissue. So when you can localize the pathology clearly, you have a better diagnosis, and that improves the patient prognosis. I'm just giving you a couple of examples. Now, this is a pure PET image, and you see this is a part of the pelvis of the patient's body, and you see these two blobs of radioactivity. Now, is this a lymph node which is malignant, or what is it? When you look at the CT, which was taken just before the PET scan, you find that these two are actually nothing but the normal ovaries of the patient, which is again confirmed on the fused PET CT image. So this is nothing but physiological ovarian uptake and not pathological. Another case wherein you have the bladder. Now this Fdg, it gets excreted through the bladder. So there is a very high dose of activity, and you may miss on underlying pathology. Just looking at this image, it looks like it's the normal bladder. But the moment you look at the CT image, you realize that this patient has a bladder cancer as well. So CT helps in diagnosing this. So when an imagologist assesses these images, he needs to first distinguish what is physiological from pathological. So there are sites where Fdg normally goes, and so that shows high uptake, like for instance, the brain, the heart, the kidneys, the bladder, the liver, which shows a moderate amount of uptake, the spleen, which again shows moderate uptake, the bowel loops, which are also generally showing a lower uptake as compared to the other areas. And you have things like the salivary glands and the cricothyroid muscle, all of which need to be distinguished from abnormal uptake. The other important thing is whenever we're going for an Fdg PET scan, we call the patient fasting. And if it is a diabetic patient who has not taken any medication, there's already a very high level of glucose within the patient's body. And when you're injecting Fdg, you get a poor image like this, where you find that the Fdg is going into the muscles. So this kind of an image is not acceptable. So we need to repeat the study after giving him insulin, and you see the beautiful pattern, and you can also see two metastatic foci in the liver, and you can see this kidney, which is ectopic in position. It's lying in the pelvis instead of lying higher up in the abdomen. Another thing which you may find quite often on a PET CT scan, which can confound your diagnosis, is what is called as brown fat. So brown fat is brown in color because it is rich in iron-containing mitochondria, and its distribution is typical and classical and you should be able to distinguish this brown fat uptake from pathology, which is from the actual pathology. Like for instance, this patient had a lymphoma. He has abnormal axillary lymph nodes, which should be distinguished from the brown fat. You also need to adjust the brightness and contrast of your MIP image. Like here, everything looks normal. The moment you reduce the brightness, you see that there is this extra lesion of high uptake within the bladder, which was a bladder cancer. Okay. Now, many times when it comes to the bladder, because there's already very high uptake, we need to empty out the bladder by giving an injection of Lasix, make the patient drink plenty of fluid, and then you will be able to see these two tumors which were getting missed on the original image. Now, what are the applications of PET in the field of oncology? It's being used for initial staging, the diagnosis of recurrence, assessing the response to treatment, diagnosis of an occult primary. You might have a patient who is having metastasis all over the body, but you do not know what was the primary tissue from which this metastasis emerged. Also for planning of treatment and to detect if the patient has a synchronous malignancy. So there are times when a patient has two separate cancers simultaneously, and all our attention is being focused on one cancer which has been diagnosed, and we may be totally oblivious of the fact that he's also harboring another malignancy. So PET CT is a whole body technique, and you can detect multiple sites of neoplastic change. And PET CT has a especially vital role to play in the field of neuro-oncology. You can delineate the tumor extent, you can plan a biopsy, you can resect the tumor, you can plan the radiotherapy fields. You also use it to assess the response to therapy. You would like to know how to differentiate a treatment-related change from tumor progression. Now, when it comes to brain tumors, a good number of brain tumors are treated with radiotherapy, and that itself will produce changes in the brain like radiation necrosis. So how do you distinguish a radiation necrosis from a recurrent tumor? So PET CT helps us to give the answer to this complex problem. So this is what a normal Fdg brain scan looks like. We know that the brain consumes a high amount of glucose, so it shows a high uptake in the cortex and also in the basal ganglia, whereas the white matter of the brain, as well as the ventricular system, it shows very little uptake. Now, I'm just showing you a few cases which were done at our center. Fdg, because of its very high uptake in normal tissues, may not be the best investigation or the best radiopharmaceutical for detecting a brain tumor. Like here, we had a patient who was treated for a glioma of the brain, and the PET CT scan shows that there is no uptake in the treated area. So if you look at the Fdg PET CT scan, you might call it negative, but we gave him another radio tracer, which is called as 11-carbon methionine. In fact, INMAS has been the first center in Southeast Asia to produce this radio tracer. And on this 11-carbon methionine scan, which is an amino acid tracer, you can see the recurrent tumor very clearly. Another case of a 10-year-old boy who was treated for a glioblastoma multiforme, who had been operated upon, and he received radiotherapy as well. His CT scan looks all right. His Fdg scan also looks fine. But when we did the methionine scan, we saw this tiny area of increased uptake, which is a subependymal metastatic deposit. Another case of a grade 2 astrocytoma, which was again operated upon. The MR shows a large lesion. The PET CT clearly showed us that this large lesion, for the most part of it, is innocuous, but it is this area which is abnormal, showing a high uptake. So we need to concentrate on this area for a biopsy for the radiotherapy planning as well. Yet another patient who was treated for a glioma with radiotherapy, and on the post-therapeutic scan, we found on MRI that there was an enhancing lesion in the corpus callosum. So is this a recurrent tumor? We were not sure, but when we did the methionine scan, we found that there was no abnormal uptake. So this is just a case of radiation necrosis, and there was no recurrent tumor, and the patient did not have to be subjected to additional therapy. We have also been synthesizing 18-fluoromesonidazole, which is an imaging agent for hypoxia. So we all know that hypoxic tissues are inherently radioresistant. So it is very useful for us prior to therapy to know how much is the hypoxic volume load, and using this particular scan in this patient with gliosarcoma, we could assess how much is the hypoxic tissue and manage it accordingly. Now, coming on to lymphomas. So PET-CT has a very vital role to play in the management of lymphomas. I will not bore you with all these details. I will just show you a few images. Okay, so coming to this patient, he came with a soft tissue lump in the neck, and on biopsy, it turned out to be a lymphoma. When he went for the PET-CT scan, then we realized that his whole body was studded with lymphomatous deposits. You can see these nodules which are present on just beneath his skin, on the chest. You can see multiple foci of deposits in the bones. These are the two humeri of the patient. The left humerus is showing increased uptake. You can see extensive lymphadenopathy in the axilla as well as in the abdomen. You also get to see this deposit in his bowel loops. So this was a case of extensive stage 4 lymphoma, and the staging was very nicely accomplished using the PET-CT scan. Yet another young male with weight loss and abdominal pain. He had these abnormal lymph nodes on CT scan, and the PET scan clearly shows us these lymph nodes as well. But what additionally you see here is this high abnormal uptake in the spleen, which means that the spleen also was infiltrated with lymphoma. You also see this abnormal uptake in the rib. So PET gives us much more information than CT when it comes to staging a lymphoma. Yet another patient who had a lump in the neck. So on PET, you can clearly see the large lymph nodal mass. You also see multiple other lymph nodes in the mediastinum, in the abdomen, and in the pelvis. And you also see this large lymph nodal mass in the nasopharynx and in the vertebrae, as well as in the skull. So the patient also had bone deposits, and this large lesion, which is present in the midline, just beneath the skull, which was a tumor thrombus in his sagittal sinus. PET-CT is also very useful in assessing the response to chemo or radiotherapy. Now here we had a patient who had a large lymphomatous mass. This is the baseline pre-therapy PET-CT scan. 6 months after the completion of chemotherapy, there is still a residual mass on CT. But the PET scan is negative. So many times you have fibrotic masses on which remain even after treatment, and you're not sure is there any residual tumor tissue present within this lesion. So if the PET scan is negative, then one can confidently conclude that this is just fibrotic tissue and not tumor tissue. So we left the patient without any further treatment, and she came back to us 2 years later, And here we see that this has become even smaller in size and it is still PET negative, meaning to say that the diagnosis was correct. There was no residual tumor tissue and we avoided unwanted chemo or radiotherapy. Coming to the role of PET-CT in esophageal cancer. So I'll just show you a simple case wherein the CT clearly showed that there is a large mass in the esophagus, which was nicely seen on PET as well. And PET additionally showed us this second synchronous malignancy in the lower part of the esophagus, which was not suspected clinically or on the CT scan. Coming to colorectal cancers, again, there is a long gamut of do's and don'ts, of indications and contraindications. But I'll just tell you a simple image of a patient with cancer of the rectum, wherein on the CT scan, you're not very sure about whether there is a residual tumor tissue or not. The PET clearly shows us this residual tissue. Another case of a colorectal cancer, again on CT, this area just looks like a simple bubble loop, whereas on the PET scan, you see this nodule, which is Fdg avid. So this patient had a bowel metastasis in addition to the original cancer. Coming to the role of PET-CT in hepatocellular cancers. So as such, as I told you, the liver shows a reasonably higher uptake of Fdg. So a moderately differentiated hepatocellular cancer will not show up on the Fdg scan. But if the tumor de-differentiates, then it would light up on the PET-CT scan. Now here we had a patient of hepatocellular carcinoma who had been operated upon, and you can see the surgical sutures out here, and the PET clearly shows us the residual tumor which has occurred at the tumor bed. Coming to the role of PET-CT in breast cancer, when it comes to just a primary breast cancer detection, it has no prominent role to play, excepting that there are some patients who are known to have a cancer in one breast, but they may be also having a much smaller early cancer in the contralateral breasts. So PET helps in distinguishing these two. Also, it helps us in detecting the axillary lymph nodes, like in this patient who had a clear-cut inflammatory breast cancer. You also see the lymph node in the axilla, and additionally, you see this metastatic deposit in the vertebrae. So this patient had bone metastasis in addition to axillary lymph node metastasis from carcinoma breast. Yet another patient with breast cancer, you see a large necrotic mass, which is Fdg avid. You also see the lymph nodes. You additionally see a tiny pulmonary metastasis in this patient. Another patient who had a clear-cut breast cancer. Now, in addition to using Fdg, we also have other radiotracers, like for instance, this fluoroestradiol. Now, fluoroestradiol is a tracer which goes and binds to the estrogen receptor. So on this particular scan, we find that the tumor is Fdg avid. It is also going to the estrogen receptors, and therefore the FES scan is highly positive, which means that this patient will respond to anti-estrogen therapies. So accordingly, we can modify our management, we can tailor the treatment according to the type of the tumor which the patient is having. It's also very useful in bone and soft tissue tumors. Like here we had a large chondrosarcoma of the rib. You can see the lesion well on CT and on PET. But additionally, you also see this thing, which is not Fdg avid, but it's a very significant finding. This patient had a left ventricular aneurysm, a calcified aneurysm of the left ventricle from a prior myocardial infarction. So it's very important when we look at the PET scans, not just to look at the tumor itself, but to look at any other non-neoplastic pathology, which also the patient may be suffering from. Coming to head and neck cancers, again, you can see here a patient was treated for a cancer of the larynx, and there is a large residual tumor in this area. In addition, the PET scan also showed us this synchronous malignancy which has occurred in the bladder. Another patient with a thyroid cancer which shows a metastatic lymph node, which is Fdg avid. Coming to bronchogenic cancers, here we have a case of a large tumor in the left lung, which is showing further metastasis. You can see the lymph node in the subcarinal region. Coming to PET-CT in pelvic malignancies, so now we have here a double shadow. So one shadow comes from the bladder and the other shadow comes from the uterus. So this was a case of an endometrial carcinoma, which is extremely Fdg avid. And yet another patient who had an ovarian cancer, where you see a large peritoneal deposits, multiple peritoneal deposits. So it was an ovarian cancer which had completely infiltrated the entire peritoneum and produced a large amount of ascites, and it has also invaded into the bowel loops by producing multiple small metastatic deposits on the bowel wall. We have something called neuroendocrine tumors. So these tumors have an upregulation of somatostatin receptors, and we have PET tracers which are binding to which are radio tracers which bind to somatostatin analogs, so they get nicely seen on these kind of scans. Typically, we use a gallium-68 Dopa scan. Now, many of these neuroendocrine tumors are well differentiated, and you don't get to see them on the routine FDG scan. But here we have a very interesting patient who had a pancreatic cancer, who had multiple adrenal cancers and a pituitary cancer, which was picked up on this gallium Dopa scan. And likewise, you have a case of prostate carcinoma, wherein we have a different kind of agent now. We know that the prostate cancers, they show an upregulation of what is called as a PSMA, the prostate specific membrane antigen. So by binding gallium-68 to this PSMA and doing the scan, you can detect very well the primary in the prostate as well as the adjacent lymph nodes. And I think you've already been explained about the phenomenon of theranostics by Dr. Pooja. So in theranostics, you can use the same tracer both for diagnosis as well as for therapy. Like for instance, here we have this gallium-68 PSMA scan in a patient who is having extensive metastatic deposits from a prostate primary. But none of these deposits is taking up this tracer. Whereas on the other hand, you have another patient who is having extensive deposits on the FDG scan. And when you do this gallium-68 PSMA scan, you find that the deposits are very well visualized. Now we have a particular tracer called lutetium-177, which can be used for radiotherapy. It emits beta rays and gamma rays, and the beta rays are used to treat the tumor. So when you bind to lutetium to PSMA, it can be used in the treatment of cancers, but prior to that, you need to know whether there is an upregulation of PSMA in the tumor or not. So in this case, since there was a high uptake of PSMA, this patient would be an ideal candidate for a lutetium therapy, whereas this patient should not be unnecessarily subjected to this therapy with no response at all. Coming to the role of PET in neurology. So PET is being used for the diagnosis, prognosis, the treatment planning, and follow-up of malignant lesions. It's used for the localization of epileptic foci, for the differential diagnosis of dementia and the evaluation of therapeutic interventions, differential diagnosis of movement disorders, objective diagnosis of schizophrenia and depression, and the localization and quantification of various receptors. So here we have, in fact, at Inmas, we did a series of patients of dementia, and using the Fdg scan, we could elaborate the different patterns of abnormal uptake in the different types of dementia. So PET-CT can actually be used in the differential diagnosis of dementia. Many times it happens that the patient who is demented may not be very easily diagnosable on clinical parameters. We know that he may be having dementia, but we don't know whether it is Alzheimer's or a diffuse Lewy body or a vascular dementia or a Creutzfeldt-Jakob dementia, and so on. So by looking at the abnormal patterns of uptake, now this is the normal pattern of uptake in the basal ganglia and thalamus, but you can clearly see the decreased uptake in the frontal lobes and the temporal lobes of the brain, and this was a patient with Alzheimer's. Likewise, in Lewy body dementia, you see a decreased uptake in the occipital cortex, which is suggestive of this particular type of dementia and helps you to come to the diagnosis. Then comes the F-Dopa scan. Now, as I told you before, that we can use different kinds of radiopharmaceuticals, some of which can go and bind to the neuroreceptors. So Dopa is a precursor for dopamine, and it is the loss of dopaminergic neurons which leads to this disorder called Parkinson's disease. So here we have a patient. This is a normal subject. You can see the normal uptake of Dopa in his basal ganglia. Whereas in a patient with Parkinson's disease, you can see the markedly decreased uptake in the caudal putamen, and it helps in the early diagnosis of Parkinson's, as well as in Parkinsonian syndromes, and also in the monitoring of the response to therapy. We have also undertaken several studies on traumatic brain injury. Here we find, in fact, we used both PET-CT as well as MRI. So here we have an MR image which shows a large hematoma in the brain, which is also seen on the CT, and the FDG scan shows that this area is showing decreased metabolism in the brain. Similarly, on the DTI study, which is also an MRI study, we could see that there's a disruption of the white matter tracts of the brain in this area. Similarly, we have also used it in spinal trauma to assess the reorganization in the brain after spinal trauma. Now we know that the brain and the spinal cord are very closely linked. All the information from the brain is passed to the body through the spinal cord, and all the sensations from the different parts of the body is transmitted via the spinal cord to the brain. So when the spinal cord gets injured, there are changes in the brain itself, which can be picked up on PET-CT. It's also very useful in the diagnosis of psychiatric disorders, especially we have done a study on depression as well as on schizophrenia, where we can assess the different patterns of metabolism in these problems. We have another kind of PET-CT study, which is called as oxygen-15 labeled radio water. Now, oxygen-15 has a very short half-life of just 2 minutes, and so it can be used to assess the perfusion, that is the blood flow to the brain. So just like an fMRI study, we can perform neuroactivation studies and see how the blood flow to the brain, which are the areas of the brain which get activated on performing a particular task. Like for instance, this was a scan which was taken with the patient at rest. And on this scan, the patient was given sensory stimuli, and you see the contralateral cortex, which is getting activated. It's also being used for Cardiac studies, so here we have this myocardial viability study where you see this area of hypometabolism which corresponds to the infarcted tissue. PET is also being used in infections. We all know that for infection imaging, we generally make use of an X-ray, CT scan, and maybe an MRI. But there are times when after the whole course of treatment is completed, we are not sure whether the patient has responded completely or he needs additional treatment. So for that, we are doing this Fdg PET scan, and we found it is very useful to tell us what is the residual amount of metabolic activity which is left, whether the patient needs to continue further with his treatment in spite of completion of the entire 6-month course or 9-month course. And this is particularly useful even in non-pulmonary tuberculosis, what we call as extrapulmonary tuberculosis. So here was a patient who had TB of the spine, what we call as Pott's spine, and you can see the increased uptake in the spinal cord as well as in the surrounding tissues. We have also used it for intracranial tuberculosis, wherein in addition to FDG, we found the methionine scan to be more sensitive to pick up the various intracranial tuberculomas. Now coming to the radiation dose. Now when you do a PET-CT scan, the patient typically is injected around 10 millicuries of FDG, and that incurs a radiation dose of 7 millisieverts. Whereas on CT, you give him around an additional dose of between 10 and 20 millisieverts at an average about 18 millisieverts from CT. So when you look at a PET-CT scan, you realize that CT contributes to 54% to 81% of the total dose. And the total dose, as I told you, comes both from the injected radiotracer, FDG, from the CT component as well. And the tissue which receives the maximum dose, the critical organ, is the urinary bladder because of the large amount of FDG which is being excreted by the bladder. So the associated lifetime cancer risk is estimated to be as high as 0.5% for a patient of the age of 20. Now again, the same question, why is it so crucial for pediatric imaging? For the same reasons which I mentioned in my previous talk about the pediatric tissue being much more sensitive than the adult tissue, and they have a longer lifetime in which to manifest radiation-induced cancer. So it's obvious that one size does not fit all, and we need to adjust the dose if we're going to do a pediatric scan. So now how do we reduce the radiation burden? So as mentioned before, we use the ALARA principle, that's as low as reasonably achievable. So any measure that is simple to use, it does not impair image quality, and it significantly reduces radiation dose should be used. All dose reduction measures are associated with trade-offs which may or may not be acceptable depending on what is the problem you're looking at. The 10-day rule I already described in my previous presentation. Avoid redundancy in investigations. Typically, we have patients who come to us who've already had a CT scan done, and then they are diagnosed with a cancer, and then they come back for a PET-CT study. So there are times when you have to tailor the study depending on the radiation dose already received, depending on the information which you already have regarding the patient's tumor. So scan protocol optimization is important. You ensure an excellent quality scan, but at the same time, minimal dose. So these are all technical parameters which we have to look at when we are acquiring these scans. I think I will not go into technical details in this presentation. So how do we optimally utilize PET-CT? The first thing is that we need to perform an FDG PET-CT only when it is clinically indicated. Secondly, we use evidence-based guidelines for guiding the way we will undertake a particular procedure. Thirdly, wherever it's possible to go for non-ionizing radiation, we make use of those technologies like ultrasound and MRI. And lastly, we consider the use of PET MRI in place of PET CT for certain clinical applications. Now, when we come to PET MR, so the whole concept of PET MR, this came, in fact, the first PET MR was a brain PET MR. It was meant exclusively for brain imaging, and that was in the year 2005. That was by a company called Siemens. And then in the year 2010, another company called Philips, they came up with this whole body PET MR, which was nothing but a PET scanner, an MR scanner. They were both separated by a distance of 2.5 meters, and the patient was lying on a rotating bed. So first he underwent the PET scan and then went on to undergo the MR scan, and the two images were fused. Later, in fact, very soon after, Siemens came up with what is called as a simultaneous PET MR, in which the PET machine is placed inside the MR machine. So this goes a step beyond PET CT. If you remember the PET CT image which I had shown you, they were lying next to each other. The patient first underwent a CT scan, and then he went deeper into the gantry and he underwent a PET scan. Whereas on a PET MR scan, the patient is completely surrounded by the PET and the MR detectors, and he simultaneously undergoes the entire PET MR scan. Now, what is the advantage of using MR? Firstly, there is no radiation dose to the patient from MR. Second, MR has a better soft tissue contrast. It's simultaneous, and therefore you are subjecting the patient to identical physiological conditions. It is multi-parametric. MR is a multi-parametric modality, so you can better characterize the tissues. You have increased functionality. You can see MR spectroscopy, MR perfusion, functional MRI using gold imaging. You do not need to use iodinated contrast agents. The magnetic field reduces the positron range. So in the transaxial plane, you can reduce the respiratory and motion misregistration. So many times it happens that the patient undergoes a CT scan, and subsequent to that an MR, a PET scan, and it tends to move a little between the two scans. So you don't exactly get a point-for-point fusion of the images. Whereas on PET MR, this problem is taken care of. The other thing is that we have reduced artifacts due to misalignment of the PET scanner as well as the MR scanner. Now, what are the applications? The first is an early tumor detection, accurate delineation of the tumor extent, multi-parametric characterization of the tumor, functional therapy monitoring, multi-parametric assessment of neuropathology, cardiac studies, investigating the effect of novel drugs, etc. Now, here was a study performed at our institution wherein we did MR and we did PET CT, and this was a post-operative glioma. We could see the recurrent tumor on the MR perfusion scan, the MR spectroscopy, which is showing us the scoline peak, the FDG scan, the methionine scan, and the diffusion weighted scan, all of which showed us this residual tumor. But the patient was subjected to two separate studies. He first underwent the MR study, then he went for the PET study. Whereas, if you have a PET MR, you can do both of these simultaneously. So these are images which were generated from fluoroethyl tyrosine, which is an amino acid, and the FET was synthesized in our in-mass cyclotron, and the images were required on the PET MR center at Apollo Hospital. So here we have this post-operative patient. He has an ill-defined mass in the brain on MR, which is showing contrast enhancement. And on the FET, the fluoroethyl tyrosine PET scan, you see how this tumor lights up, and you can delineate the tumor extent extremely well. Another similar case of a multi-modality, multi-parametric study using PET and MR on a brain tumor, and using these modalities, you could clearly see the recurrent tumor in this patient. Yet another patient with a prostate cancer who had already been operated. His prostate had been removed, but the PSA levels were rising. So on the PET MR, here we did a choline PET MR scan. Choline is a marker of lipid metabolism, and there is a high choline uptake because of the rapid membrane turnover of these rapidly dividing tissues. So we see here, this is actually a section taken through his pelvis, and you can see the two pelvic bones, and you see this high uptake in this area from FET uptake, which was a malignant metastatic deposit. Similarly, a case of liver, actually it was a case of a colon cancer who had deposits in his liver. So you can see these metastatic deposits in the liver extremely well on the PET MR scan. Yet another patient of prostate, the MR image shows the tumor. You also see this suspicious lesion, but when you do the PET MR scan, you clearly see that the tumor is restricted only to this area, and this lesion is just a hyperplastic nodule. In head and neck cancers, again, PET MR is very useful. A 53-year-old woman with a tongue cancer on the right side, this abnormal tissue on MR, which lights up on the PET scan, and you can delineate the extent of the tumor extremely well. Yet another patient who had a tonsillar cancer. This is the CT scan. Now, after the surgery, we could not really make out where exactly there is any residual tumor, but using MR and then using PET MR, one can clearly see how well delineated the residual tumor is. Similarly, another patient with lung cancer, wherein the MR image shows you this large area, but you don't really know how much of it is cancerous and how much of it is collapsed lung. So you go for a multi-parametric MR, you do a diffusion study and you see areas of restricted diffusion. You do a perfusion study and you see the areas which are showing high perfusion, which corresponds very well to the abnormal uptake, which is seen on PET scan. Now, the most promising clinical applications of PET MR are in neurology and neuro-oncology, in head and neck, in the liver, in the pelvis, musculoskeletal system, breast, and for imaging of the heart. So just a final word before I conclude. Now, the present concept for a patient, especially one with cancer, is that the patient has an illness, and whatever be the lesion inside, it grows sufficiently to produce signs and symptoms, and then he approaches the doctor and comes for the diagnostic investigations, and then he's treated appropriately. But the futuristic concept is that those who have a particular genetic predisposition to a particular disease, they can get their genomic studies done. Let me take an example. You have a patient with a breast cancer. Now, any patient who is having a breast cancer, the incidence of cancer in his or her relatives becomes higher. So one of these relatives undergoes a genomic study, and that patient is, and that individual is seen to have a particular gene, that is the BRCA1 and BRCA2, the BRCA1 and BRCA2, which we know when they mutate, the patient has a high risk of cancer. So let's assume that this patient is having a BRCA1, BRCA2 mutation, and so is at a higher risk of developing cancer. So the patient undergoes regular follow-ups using either mammography or MRI, and an early cancer is picked up. Now, there is a particular protocol of how you manage an early tumor. Generally, it is operated upon. But in addition to just doing a routine surgery, if you find out what are the particular receptors, the tumor receptors on that tumor, you can then treat it, maybe even without surgery, you can treat it much better. So this patient undergoes the study for assessing whether it is estrogen receptor positive, progesterone receptor positive, and you find that there is a particular receptor called the HER2 new receptor, which is positive. Now, there is a monoclonal antibody called trastuzumab, which can be used for treating that cancer. So you can do a PET scan labeling that particular drug. So we have the zirconium-89 labeled trastuzumab, which you can use to diagnose and see whether this patient will respond to the treatment, which is typically called Herceptin treatment for this kind of cancer. And if you see the positive response, then you go ahead and you treat the patient. So you don't just subject every patient to a particular homogeneous type of treatment. You personalize or customize the treatment depending on the type of cancer the patient has, the type of tumor receptor antigens that you detect, the kind of response that you anticipate to various tumors, and so you make an early diagnosis and an early and effective treatment. So with that, I'd like to end once more on the same note that we have a huge gamut of investigations which are open to us, and just because they are available or they are affordable, it doesn't mean that we need to go for each of these investigations. We need to image gently and image wisely. Thank you. I think with that, I am stopping my presentation. So if there's any question, I could. If anyone has any questions, I could.
Dr. Umesh is muted. Please unmute him. Are you not? Hello? CIS?
Yes, ma'am.
सर को अनम्यूट करिए. सर को होस्ट नहीं है क्या?
Okay, so I was muted. It was likely that I got disconnected because of internet issue, and then I rejoined. So this problem occurred because of that. So thank you, Dr. Maria Souza. It was very enlightening lecture indeed. We saw, a lot of uses of these imaging techniques, especially the hybrid ones, to diagnose different diseases, not only cancer, but different other diseases that occur in our body. So, as you rightly said in the end, that you don't have to use all these imaging techniques just because they are available, but in consultation with your treatment or therapeutic team, whichever is most desired for the intervention, that can be taken up. So thank you for enlightening us with your.
There are a couple of questions, sir.
So I do not see any question because
maybe because you rejoined, it is there. I will read it. Yeah. Dr. Maria, Can you put your camera a little lower so we are able to see your half face? Yeah, so can you be, that would be better. Yeah. So Antara has asked a question, which rays, ionizing or non-ionizing radiations are used for eye LASIK surgery, and does it increases the chance of ocular melanoma in the patient?
Yeah, so just as I had answered someone who had asked me a question in the previous talk, LASIK surgery doesn't really fall into the domain of a radiologist. So I think this question should be better put for an ophthalmologist. They will be able to answer it better. I'm really not an authority on this, so
Okay.
I cannot answer this.
Okay, okay.
Yeah, I have one question. No, it is just to understand how we can use research further to identify more new tracers. So the question is that how the tracers are developed or identified. Can new biomarkers identification help develop new tracers? And what is the procedure actually?
So develop a radio tracer again falls under the domain of a radiochemist. We are radiologists. We make use of the tracers which are being
But
produced.
Pooja is here, Maria. She has joined.
Maybe
I saw.
Pooja could answer the question.
But anyway, you complete what you were saying. Yeah.
Yeah, so I think the radiochemist would be the right person to talk about radio tracer development. But having said that, probably these biological studies which identify a particular tumor antigen or a particular tumor receptor which needs to be targeted, once the biological studies are able to identify that, you need to identify a particular radio tracer which can bind to a particular compound which will go to that particular site. Like as I just gave that example of zirconium-89 labeled trastuzumab. Now this is a monoclonal antibody which is being used for the Herceptin positive breast cancers. So the first thing is to be able to identify an agent which can go and bind to these receptors, which requires a lot of extensive molecular studies, starting with molecular modeling to the tracer development. But the exact steps of that process probably should be taken up. I think I can see Pooja here, and she'll be able to answer that question.
So Pooja, can you answer? Although you have answered yesterday, then again you can tell us. So he's asking that how can you make a targeted? That's what you're saying, Prasada, or you want to repeat your question?
Yeah, the process of developing radio tracers for diagnostic process. So do you need to study the biomarkers related to particular pathology to develop the radio tracer, or there is some other method?
Definitely, because some of the biomarkers are very specific to certain kind of tumors or specific kind of tumors. So same radio tracer, you cannot, get into, like in every subject or any clinical pathology, you cannot use the same tracer. But we are using Fdg fluorodeoxyglucose in all the modalities because it goes in infection, it goes in inflammation, it goes in any kind of tumor pathology. So on the basis of that, like Fdg is a very much used radio tracer, as Dr. Maria also will say that, because it is readily available, and we inject that into every patient of any right, ma'am, that we do in today's scenario, that because Fdg is available, so Fdg is injected into all the cancer patients, or maybe infection to distinguish infection from the tumor pathology. We need something which is very specific. So we develop on the basis of the receptors that are overexpressed on certain kind of tumors. For example, high-grade glioma or gliomas, they overexpress large amino acid transporter. So large amino acid transporters becomes the target of interest. Then depending upon the target of interest, we develop some of the radio tracers like methionine based, like tyrosine based, like dopamine based radio tracers that uses this receptor to accumulate at the target site. Because compared to the Fdg, like for fluorodeoxyglucose, it goes in all the cancer, wherever glycolysis is there, it will go and sit over there. So In brain also, it becomes very, very difficult to delineate the tumor or to identify the tumor if you're using the same radio tracer in that case scenario. So we need to develop according to the cancer pathology and the receptors that are, or the biomarkers that are overexpressing in that, or the specific the receptor enzyme or transporter is overexpressed on that particular kind of a cancer pathology or a pathophysiological condition. It could be cancer, it could be neurocognitive disorders, it could be any pathology.
Okay, thank you.
I have a question, Dr. Yadav, can I ask?
Yeah, please.
Or you have another question?
I was asking if you have some questions in the chat box. So there are
no, I don't. I will see it, but I will ask first the question. So it was a wonderful talk, Dr. Maria, and I really enjoyed it and learned a lot actually. I have a question that are you people, is that this artificial intelligence, lot of things are being talked about in terms of the personalized medicine or individual medicine. And I've seen in one project in the from the AIMS, where they have said that we can have the imaging from particular, collect the images, and from the images we can create a definition, and from that definition we can create that if these kind of lesions are there, then these the person will respond to drug or this particular drug or this particular or the radiation. So is it that something it is really clinically viable, are you thinking, or this is all research only, or what is, and you can also throw a little bit of light that whether it is followed seriously or something, because there was a large discussion done this time on the cancer consortium by ICMR, and they had a one call on the AI based imaging interpretation of the imaging interpretation. So is it in all the diseases, but because it was cancer consortium, so it was being discussed. So can you really throw some light?
So actually, ma'am, when you talk about AI, there is a tremendous amount of research going on all across the globe. But for it to be utilized in the clinics, it will take some time, because we are practicing evidence-based medicine. And unless there is concrete evidence that a particular thing is going to positively affect the patient, it will positively affect the patient management, it is not being employed in routine clinical practice. But having said that, there is extensive amount of research, especially in AIMS. Very recently, I came across, I was just listening to Dr. Padma, who's heading neurology out there. And she was in fact talking about they're trying to develop some kind of an AI device wherein a person who is about to have a stroke or has just had a stroke does not need to go through all the complex MR sequences which we need to do, but they just try to diagnose it based on a simple CT scan, which takes just a few seconds to acquire. But it'll be a long time before it really comes into the clinics. So having said that, I think there is a lot of future in AI, but for it to have a concrete benefit, it will take some time. So
okay, and then I have another question, that you were in last of a few of your last slides, you were talking about the personalized medicine. Yeah. What you were trying to say that if we take an image and I really could not make out what you were trying to say. So is that make out means I just want to be more clear about it. And then I just wanted to know that when you talk about this personalized medicine, then this imaging of the, you have to mix this outcome of the imaging images which you have got from the deceased, from the patient, along with some of the genomic or transcriptomic say outcomes also, and then you have to go into the personalized medicine, or you can just do it in a unique manner.
Yeah, so actually, ma'am, personalized medicine is again something which is still under research. As you just mentioned about this radiogenomics, wherein you take the radiological signatures with the genetic signatures, that's the best way to go about it, and that's the most effective way of doing personalized medicine. But it will be a while before, from research, it matures sufficiently to be utilized in the clinics. Nevertheless, there are cases wherein, like, you may have a particular tumor, which in the olden days you have tumor X, which will be treated with a particular Y or Z drug regimen. Like you have a lymphoma, which is of a particular kind, you have a CHOP regimen, which will treat that lymphoma. But we have been able to see that a lot of people don't really respond to that particular regimen. And now there are lots of studies going on to see what are those particular tumor markers which will tell you whether a patient responds or does not respond to a particular disease. Like now, even in the one of the slides which I showed you about the gallium-68 PSMA, this is a particular tumor antigen, which if a person overexpresses, then he can be subjected to what is called as lutetium therapy. So we have a particular PET agent called gallium-68. Gallium-68 labeled PSMA, which will go to that particular receptor. If it goes to that particular receptor in high amounts, then we know that this patient is going to respond to the lutetium therapy. And if it does not, then there's no point in subjecting him to all that expense and burden of that extra radiation. So personalized medicine is being practiced today when it comes to tumor antigens, tumor antibodies, hormone receptors, neurotransmitter receptors. But the ideal way would be this radiogenomics, wherein you integrate radiological data with the genetic backup, which is still in the research stage, and it will be a while before it can really come to the clinics.
I mean, if you would
Okay.
put some light on the radiogenomics per se, like radiogenomics, like how we are going to do the radiogenomics when we're talking about the personalized medicine.
Yeah, so right now it hasn't yet come to the clinics, but what the researchers are trying to do is that they are assessing all the entire genome of the patient. After the genetic sequences, you identify those defective genes which are causing the tumor, or maybe those particular genes which will tell you whether the tumor will respond to a particular therapy or not. That information clubbed with particular imaging signatures. Like for instance, on imaging, you can find out what is the level of angiogenesis of a tumor. You can do an MR perfusion, you can do certain PET studies. If you find that the tumor is showing a high degree of angiogenesis and your genomic studies shows an overexpression of VEGF, that is the vascular epithelial growth factor, then you know that an anti-angiogenic therapy like bevacizumab will be very effective for this patient. So you combine the two data together using AI, and then you assess which patient will respond to what best. But for it to be utilized routinely, it will take a while. But I'm sure that is also around the corner, and we should be able to.
But ma'am, one thing that we are doing is making use of hyphenated technology, like combining MRS to the PET imaging or PET MRI. So this technique also is providing the little bit of that kind of details that we intend to get from the radiogenomics.
Yes, yes.
So
ma'am,
yeah.
Yes.
Yes, ma'am. So ma'am, this can also become the road to personalized medicine, because you're able to identify non-responders and responders only on the basis of like the imaging and the therapy that you are giving. Therapy could be radio and nuclide based, and maybe chemotherapy. So ma'am, all these things, all these factors that will come into picture when we talk about radiogenomics, definitely it will be a tool ahead to understand all the mechanism, and so how we will be combining this or corroborating those results, because radiogenomics is something which, if genomics means it will be taking the SNPs into picture.
Yeah.
So, and radiogenomics means after the radiotherapy or the what gene we are, like after radiotherapy we are going to take those radiogenomic DNA or genes or it is like it's only the genomics that we are going to corroborate with the radio?
No, it will be applicable both times, both before and after radiotherapy. But using AI, they will integrate all those things together. Like if you have a gene which is showing overexpression of VEGF, and you correlate that with an increased angiogenesis on an MRI perfusion scan, then you integrate these two information, feed it into your AI system, and it will identify, okay, this patient has high angiogenesis and is likely to respond to this therapy, and then you plan it accordingly. But for that, you need to collect a huge amount of data on the genomic front and the radiomic front, and then integrate the two, which is a big challenge in itself. But I think we have accomplished many challenges of integrating PET and MR, and I'm sure this is also on the horizon.
Thank you so much, Pam, for putting light on this. Thank you so much.
Yeah, thank you, Dr. Maria Souza. I think today's session, both the lectures that you did, our students must have benefited a lot with that. And the question and answer session was also very enlightening. So I think it is time to close the session. And thank you very much again. And the organizers can take it up further.
Also, thank you, sir. We are grateful to the chairperson, Professor Umesh Yadav, for conducting the session and discussions. So let us now take a lunch break, and we will join back at 2 p.m. to proceed with the last session. Thank you.
Savio? Savio?
Yes, ma'am.
ये हटाओ. हाँ. Okay, so we have to do. Is that everybody's here? Orders place नहीं करने आज ही. तो इसका ये जेम साइन चाहिए. जो वो प्रेजेंटेशन थे, इधर आना. हेलो. वो क्लोनोजेनिसिटी का प्रेजेंटेशन तुम लोगों ने मुझे दिया था. ये पलक ने मुझे भेजा था. पलक को कह दो मुझे दे दे जरा. ऊपर है वो, तुरंत लेके आओ. I'll be giving a presentation on the clonogenic assay. So I'll be just just give me some time. We will discuss it. And there is a experiment is going on here. Just give me 5 minutes. I'll be starting the presentation. You can ask your other colleagues also to join the session. Can you see my slides? Hello, Savio, slides
Yes,
दिखाई
ma'am.
दे रही हैं? हाँ,
Yes, ma'am.
ठीक. So you have been told about the clonogenic assay, and so I just want to show you that how clonogenic assay is done. So it determines the cell reproductive death after the treatment with ionizing radiation. So what you do that you take the cell culture. and any kind of a mammalian cell culture you can take, and you can treat it with the ionizing radiation. Chronogenetic assay can be done for all kind of experiments, but because this is the specifically a radiation biology course, so we are talking about the ionizing radiation, and it can be used to determine the effectiveness of other cytotoxic agents also, like drugs also. So what you do, that you take a cell culture, and in that cell culture you take different plates, and in one set of plate you do certain treatment, in another set of plate you don't do any treatment, and the third set of plate you can do more than one treatment also. So there will be a control plate and there will be a treated plate. So and after that, what you will do, that you remove medium and protect cells with a thin film. So what you will do, that you will put a kind of a film over, say kind of a film over there, and then you will irradiate it. Irradiate means like you can take it to the X-ray irradiator, gamma irradiator, and you can fix the dose. Dose means you can fix the radiation doses. So radiation doses can be 2 gray, 4 gray, 6 gray, 8 gray, and depending on the cells, you have to take the do the irradiation. But because 2 gray is supposed to be the dose which is used clinically, so most of the time we start any experiment for the standardization from the 2 gray, but it does not mean that we always do at the 2 gray. For in order to interpret the dose dependent effect of the radiation, you have to do it on the increasing dose of the radiation. So but we start it from one control where there is no radiation, then 2 gray, 4 gray, 6 gray, 8 gray. You can go up to certain higher grays, but you have to remember that mammalian cells are very sensitive, and if you will irradiate them at a very high dose, all of them will die. And you do not want to conduct such experiments where none of the cells are live. You want that some of them will be damaged and some of them will not be damaged. Then only you will be able to monitor the effect of the radiation on the particular cell. Now you will add the fresh medium to it. After irradiation, you'll remove the medium. Why you will remove the earlier medium? Because in that medium there will be certain dead cells which will be removed, which will be floating over there. And so the remaining one will be kept in the incubator, in the CO2 incubator, and they will be left for a few hours, 2 hours to 4 hours. And after that, when they get adhered, you can trypsinize them. Why do we trypsinize the cell? Cells were trypsinized to be removed from the as they are adhered in a say Petri plate, and then you divide it into the different number of plates, and you replate it. So this after replating, why are you replating it? You are replating it so that the clonal separations of the cells can, because each cell is not in the same phase. Some of the cells will be in the say G1 phase, some of them will be S phase, some of them will be G2 phase, or some of them will be M phase. So you have to do the separations of those particular cells in the different plates, and after doing the separations of those plates in the different plates, you can the identify and quantify cell renewing mammalian cells derived from in vitro cultures as well as from the ex vivo tissue preparations of the different organs. So you can do the chlorogenic assay from these particular cells. And then after that, when you will say plate them over there, you have to leave these cells in for a particular say a few days. You can leave it for you will find that the now how clonogenic assay is done, that has been told to you very clearly. Let me first go through the presentation, then I will try to make you understand. So what happened that when you replate these say cells there, then what you have to do that you have to grow them for a very little bit longer time, and then after growing it will be developed as a colony. There are some colonies of the cells will be formed, and you have to calculate the number of those colonies, and depending of, for example, if you plate say 100 cells in one particular petri dish or plate, and after say 7 days 8 days, if you find that the 60 colonies have produced, so you will say that your plating efficiency is 60%. So most of the time it is supposed to be that your plating efficiency should be between 30 to 60%. If it is higher, very good, but at least it should not be lower than the 40% or the 30%, because otherwise you will not get a proper result out of that. So the endpoint of this assay is observed depending directly on the reproductive integrity of the individual cell. So what do you mean by reproductive integrity? Because you have irradiated those cells, so now those cells have become, there is a genomic instability there. They are not functioning properly. So only few of them will be in a proper will be able to reproduce, means divide and produce the other cells. So that is called as the plating efficiency, that number of colonies formed in 200 divided by number of cells seeded. That's what I told you. I told you in a simple word that how you can see, and then you can calculate from there survival fraction of the cells. So what I want to say that if I have plated one particular cells, for example, HEK cells, HEK 238 means human embryonic kidney cells, into the plate, and we have put 100 plates, and out of 100 cells there, and out of 100 cells, if there are only certain number of colonies have appeared, then from there, by this particular formula, you can calculate the plating efficiency. And if in your so the first parameter in this work is this, that you need to understand that your plating efficiency is good, and if your plating efficiency is not good, then you should not go ahead with that experiment, because plating efficiency is one thing which will decide that the experiment has gone in a right place or not. Because if there are no colonies are found out of it, what will you do? So you should first try to do the plating efficiency experiment, and then you should do the full-fledged what you call clonogenicity assay. So then you can calculate the survival fraction. So number of colonies formed divided by plating efficiency divided by number of cells dead into 100. So that is called as the survival fraction. What do you mean by survival fraction? Means how many cells have survived at a particular radiation dose out of a particular cells which you have taken. If you have taken 1 million cells, then how many colonies are found out of those cells, and it should be divided by its plating efficiency. By that you will know that what is the endpoint. By that you will be automatically know that it's what would be the plating efficiency. Then you will divide it by the number of cells seeded into 100. So that kind of a plating efficiency, dividing by plating efficiency, you are removing the error while you are seeding the cells into the different plate, because you have to do these experiments in triplicate. So in biology, when you do an experiment, you should at least do every experiment in the technical replicates and biological replicate. What do you mean by technical and biological replicate? Technical replicates means you have more than one you have repeated that experiment more than one time, maybe 3 times. And biological replicate means when you are doing one particular experiment, sorry, I'm wrong. When you are doing biological replicate, you have to repeat the experiment 3 times. When you are doing technical replicates is that you are at this one first time when you are doing that experiment, that should be done down into the 3 different concentration or 3 different vials or 3 different wells or 3 different plates, so that and then you have to take the mean of those results to say that what is the correct result. So in the biology or any kind of experiment, even when you do titrations in the chemistry, you are supposed to take the reading at least 3 times. If you take it 4 times, it's better. You take it 5 times, it's better. So that is what is called as the assay endpoint. Now, what is the clonogenic survival? What is the principle of it? For example, if you have taken 100 cells seeded and 70 colonies are formed, you call it that plating efficiency is 70%, or so that is what I have already told you. When you have seeded 2000 cells and 32 colonies are found, then the survival fraction 32 upon 2000 upon 0.7. So the survival fraction is 2.3. So now you have to understand. Now the question arises, what do you mean by colony? If you don't understand by the colony, then say colony is a definition which is actually it means that it is that every colony that has been developed from a different cell type. Fine. So that is called as the colony. And so if there are like I don't have visibly the plates here. I think it was shown while the presentation was being shown to you. So those kind of this is actually actual plates in my laboratory from where we have taken the photograph to show you. So colony counting has to be done. You can do colony counting manually. You can do it using a particular colony counter pens come. Nowadays, there are software come which are inbuilt in the microscope. You can put your plate on the platform of the microscope, and by running that particular software, that will count the number of colonies. Now, what is the methodology? Now, the methodology is that you have a monolayer culture, then you have you put here the trypsin, and then after trypsinization, you will say, I don't know whether all of you know it or not, this is called as the cell culture flask. You can do cell culture in these kind of a petri dishes also, and you can do in the flask also. In flask, it is easy to carry because it has a cap, proper screw cap there, and it can be of a bigger size. So if you want to do a lot many culture and you want to do a bigger experiment, number of plates are there, so you can take the culture from one particular flask and divide it into the 100 petri dishes. So like this is, you take a monolayer culture, you trypsinize it, you take the cell suspension, then you seed the different dishes. Now what we are doing here, we are starting the seeding from 100 cells, 400, 1000, 10,000, depending on that. You do the say seeding. We are showing here 10,000 cells, but we generally never seed for clonogenicity assay 10,000 cells. We never try to, we try to go up to 3,000 and 4,000 cells because we don't want that the dish is already filled, because there should be a place for the cells to grow there. But and here what I am trying to do here, that I have taken 2 gray, 4 gray, we are taking different dose of the radiation. Why? Because at the higher dose of radiation, very few cells will survive. So if there will be no cells, how will you do the colony counting? So with the increasing number of increasing dose of radiation, we increase the number of the cells which are seeded. This is not a universal truth, but for a practical, for an experiment to be feasible, to get certain result out of it, this is the way to do the experiment where you are doing the clonogenicity assay in the presence of radiation. So these kind of things have to be done, and you can see here that we have shown here X-ray dose. Why we have shown X-ray? Because in JNU we have a X-ray diffraction machine which is called as the Precision X-ray 225. This is the name of the machine. Precision X-ray is a company, American company, which make this a specialized machine, and we are using X-ray machine also. Yesterday you saw that Professor Dr. S.K. Mishra have shown a gamma irradiator also to you. So we use gamma irradiator also, we use X-ray irradiator also. See, earlier people used to use gamma irradiator in the lab also more, because most of the time for the human irradiation, gamma irradiator machine were used. But now there are different techniques, different sources of irradiations are used. And looking at the number of, looking at the accidents which have happened because of the gamma irradiator, people think that if you use X-ray irradiator, it will be more safer for the researcher. And now very state-of-the-art machines have come where irradiation happens in a closed chamber, and you put your plates, your animals, all kind of your experiments can be done in a closed chamber, and you can monitor it from a very distant place. So this is all called as the, so then here it is written incubate it 1 to 2 weeks. So you can see here that we are proposing it that it should be incubated 1 to 2 weeks. Why 1 to 2 weeks? Because the colony formation takes time. And if it takes 10 to 15 days to form the colony. So that is why you have to leave the plate for certain time. And then you can see that from there, then you calculate the surviving fraction as the way I have told you in the earlier slide. Then we do the counting. That's what I said. You can do manually. You can do manual along with the, you can use the pen to say peripheral at the peripheral side of it, and then you can do even the automated counting also, which I was trying to tell you. And other than this machine, this is another machine. It's not a microscope, but in the microscopes also nowadays softwares come where you can put your petri dish and the counter moves automatically and it does the calculation. It does the counting, and then the outcome is stored in the computer, and then from there you can get your results. Now what you do that for the chlorogenicity assay, we put a cell survival curve over there. So cell kill is the result of single lethal hits plus accumulated damage from 2 independent sublethal events. D is the dose in gray. Alpha is the cell kill per gray of the initial linear component on a log linear plot. This is, so I have to tell you one thing here. Whenever you try to do the cell culture, or why? Because you are taking cells here in millions. So the kind of events which are occurring again, they are in the, so in a higher number. So if you are doing anything in a very high number, if you will try to plot millions on a particular axis, it is not possible for you. So what we do, that we convert it into the, we take those cells, we take those numbers in the log. So if you do anything in log, you can take a very small number also, and you can plot a very high, a very big number also. So there are certain definitions are written here over here, that so some words are being you are being introduced with that. D is the dose in the gray, alpha is the cell kill per gray, beta is the cell kill per gray square of the quadratic component of the survival curve. Alpha on beta describe repair kinetics. What they are trying to tell you here, that so now if you look at here, you can see that they're trying to tell you that if there is no radiation was given, then what kind of there will be 100% survival, and their 100% survival is being represented by 1. And below 1, then slowly survival is reducing with the increasing dose of the radiation. On this axis, you have put the increasing dose of the radiation. So this is called as the survival fraction. You can calculate survival fraction by E power to minus alpha d plus beta d square, and you can calculate it over there, that what is what is the cell survival over there. So now you can see, please try to look into that. We are trying to show you here that there is one curve going here, then another curve going, very sharp curve. This is an ideal clonogenic survival curve, which generally we don't, it is not necessary that you will observe this kind of a clonogenic survival curve in all the cells, but you should get this kind of a curvature over there, and you should try to look into that there is a kind of a, initially the survival was reducing very slowly, but it was increasing very fast when you have increased the radiation. So this is what it is being shown over there. And again, I would like to, so this is called as the clonogenic survival curve. So this is one of the experiment where it was shown that how a surviving fraction can be calculated. And this was actually, first of all, shown in 1956, and it has been taken from a particular book to show you that how initial survivals were done. Dr. Chakravarti, I will finish it and then I will have a question answer session. Is it fine? So I would finish it and then we will have the question answer. Are you able to hear me? There is any hearing problem or something? Am I clear, Savio? Meri आवाज आ रही है?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
Okay. So we are in order to do the discussion, I'm just showing you some random results from my laboratory, and NIH 3 cells are used here, and where the radiation was given 0 gray, 2 gray, 4 gray, 6 gray, and 8 gray, and the cells were seeded at the, as I have told you, these are the number of colonies which are obtained. As I said that these are in the triplicate. Then we have calculated average number of colonies from this triplicate. We have calculated the plating efficiency. Then we have calculated the average plating efficiency. And then when we have added a drug over there, fine. So when we added a drug, and AMG 510 is a radiosensitizer. So this is an approved radiosensitizer, and when they have added it, you can see here that the average number of colonies were actually if you look at this, so AMG 510 was actually used. DR means drug plus radiation. So you have added the drug also here, which is here AMG 510. So as they are added they have found that the plating efficiency and the number of average colonies are reducing because you have added a radiosensitizer over here. So if you add the radiosensitizer, so they are trying to tell you here that if you have used a particular dose of the, I'm not going here, first I will explain you here, that when you have added the AMG 50, so then your curve has, you see this particular line where there was no filling. This is a kind of a cursor. This is a kind of a identification kind of a bar there. So if you look at the data point, so you can see that when you have added AMG 50, then the survival is reduced as compared to the radiation alone. So this is a particular curve for a radiosensitizer, which suggests you that if you add such kind of a drug along with the radiation, then the survival is further reduced. And they are showing you here also with the plate that if you have drug only, you have control only, you have radiation. When you have radiation plus drug both, then the very few colonies are seen there. These are actually the plates from our laboratory. We have created this kind of experiment, kind of pictures for you in order to make you understand about it. So this is all about a small presentation. We just wanted to give you a feel. Now, anyone who wants to ask the question can ask the question. Dr. Chakravarti, you were asking some question to me. Hello. So is there any question by any participant? Do you want to ask any question? Actually, we have been talking clonogenicity at least one presentation, one video, twice Professor Dwarkanath have clarified you because it is a gold standard for the radiation. So that is why we have included it in our presentation. Is there any thing which you people want to ask me? We can initiate the discussion if any one of you will ask, because I myself cannot, can I ask all of you to please open your video also so that we can take one photograph? Hello? Savio, just अपना video on करो. All of you are requested to please switch on your videos if you are here. If you have just logged in and not here, then it's not yours. Nobody's here. Palak has gone for the practicals, but the people who are here, they should be Ayurveda biology students are doing experiments in my laboratory only. So if others are here, they can switch on their say videos. Sir, you joined just now. Dr. Dwarkanath, you joined just now.
Yeah.
So I told them about the clonogenicity, but there are no questions.
Okay.
So I am telling them that if there is any question, we can have it.
Sure.
So as Dr. Dwarkanath here, then you have a very good opportunity to discuss with him. Anybody can ask any question if you really want to ask anything. Can I ask a question from any one of you that why do we call it clonogenicity assay? No. Okay.
Because we are assessing for the colony formation and we are eventually calculating the number of colonies, and for that is why maybe.
Do you really understand that? How do you define a colony in the mammalian cell?
Define a colony.
Like for example, how do you know that this is actually a colony?
By watching the Petri plate, and like ma'am, you showed the Petri plates. Just you showed the colony formations, and then before like if you give the drug treatment or if you give the radiation treatment, then there is a difference in the number of colonies which we get, either decrease or depending. So, and you also showed that we can either do it manually, or also now other softwares are also available for doing the same. So that's what I could understand from your slides, because this is a very new concept for me.
Okay.
Hello.
Yeah. You can, Dr. Dwarkanath, you were saying something.
No. I'm just listening to her, nodding my head.
Okay, Ritesh, yes, ask. Yes.
Ma'am, I think this is the number of cells present. We just define like more than 50 cells. We can categorize the colony size accordingly. The number of cells.
Sir, I'm just coming 2 minutes. You can just talk to him. 2 seconds give me. Yeah, so why 50 he's asking, Ritesh?
Why 50 cells? Why not 500 cells? Why not 10 cells?
Yes, sir. Actually,
God said, let there be 50 cells in a colony, so it is now 50 cells, is it? I think I mentioned this in the talk on cellular radiobiology. I did mention very emphatically. Okay. Anyone else? Prachi? Why a group of cells together, 50 or more, qualifies to be called a colony, and less do not get qualified to be called a colony? That's the question. Why 50 cells before we call it a colony? And what is the relevance to radiation-induced cell death? And as Dr. Vibha started the discussion, what is so clonogenic survival about it? What is clonogenic survival? You said because colony and clonogenicity still needs to be linked up. Okay, we'll come to that. Now we are discussing, as Ritish or somebody said, 50 cells, a group of 50 cells would be called a colony. The question is, what is so sacrosanctal about 50 cells? Anyone from the students who joined the session? All right. Well, let us address, for having asked the question, we should answer that, right? Now, first we will answer why 50 cells, and then go back to colony and clonogenic survival and relationship to radiation-induced cell death. We have three issues we discussed. 50 because 2 to the n is the number of cells for every division, right? If I have one cell I put in, if there is no division that takes place, 2 to the 0 is 1. There is one cell. If this divides once, n is equal to 1. There will be how many? 2 to the 1, 2 cells. If it divides twice, n is equal to 2. 2 to the n is 2 into 2 to the 2, that is 4 cells. Like this, 3 times it divides 8 cells. 4 times it divides 16 cells. 5 times it divides 32 cells. 6 times or more. The assumption is, if after you have irradiated or treated these cells with an agent which is cytotoxic in nature, and if some cells escape this cytotoxic attack, whether it is radiation or any drug, and in such a way that they retain their ability to infinitely divide, which is the causative factor for the development of tumors. Now, it's by observation, several empirical observations, any number of observations, that if a cell after a treatment has retained the ability to divide for 6 consecutive generations or more, is likely to retain the ability to divide for unlimited time. Why? Because after irradiation, it has been observed there are groups of 2 cells, 3 cells, 4 cells, 6 cells. I'm deliberately giving this number so that somebody will question later and we can address that issue. But indeed, it's true. It's not I'm coming up with. But one cell that was irradiated, if you find 3 cells, some division has taken place, right? If there are 6 cells, that division, some division has taken place. And then you will find some with 60 cells, 80 cells, or whatever, and then any number. But if you took cells from these groups and if you replayed them, you will find that the cells from groups of few, like 3, 4, 5, 6, or whatever, very rarely they form colonies. But if you took cells from a colony containing large number of cells, much more than 64, then to a very large extent, most if not all retain the ability to form colony. So this tells us that if the cells have divided 6 to 7 times after a given treatment, most of the cells in that colony indeed have retained the ability similar to the unirradiated parental cells which was irradiated, whose sisters and brothers proliferated and made colonies in the unirradiated population. So these surviving cells which did not get killed have the ability to proliferate unlimitedly. So therefore, to cut the whole story short, if a cell after a given treatment has divided 6-7 times, it is deemed to have retained the ability to divide forever. That's why we say a colony containing 2 to the power of 6 or more qualifies to be called a colony, and they can in fact repopulate. If it was a cell left behind in the tumor, it can regrow. Right? Now coming back to the first question, Dr. Vibhas, why is it called a clonogenic? Why is it called a colony or a clonogenic survival? It's actually clonogenic survival assay, inferred from the colonies that the irradiated cells formed. Colony or clonogenicity are one and the same. Clonogenicity means ability to clone themselves. That is carry on unlimited mitosis. When they did this, they'll form a colony of their own. That's why it's a colony. If they retain the ability to clone themselves unlimitedly, and they all stay together, therefore they look like a macrocolony, a colony of cells visible to the eye. That's the relationship. Right? Okay. So the trick is you keep asking questions so that your faculty can answer. Otherwise, you will have to be answering questions from the faculty, like Dr. Vibha asked.
Sir,
So
I have
Ritesh,
one more question.
Okay.
Yeah, sure, Ritesh. Ask.
Actually, in case of chemotherapeutic drugs or phytochemicals, in normal MTT or trypan blue assay, we just use the dose, I think, which is lower, like in case of clonogenicity assay, there we reduce the dose to 10 times less. So is it the case in case of radiation also?
What?
Actually,
The dose that you use
yes, sir,
has no rational to the assay that you are going to employ. Has no assay that you employ. When you look at the dose response curve in radiation response, you go from no dose, that is 0, to as much as you can manage to generate colonies and be able to count reproducibly and reliably. You go to 10 gray, even up to 20 gray in case of resistant tumor cells. Now, when you do the MTT assay, MTT is a metabolic viability assay, right?
yes,
A short-term assay. You can still do, you can do these doses. Nobody stops you from doing. But if you want to use only one dose, you wouldn't use a very high dose simply because there may be enormous amount of interface depth that your MTT readouts are almost flat even from the 24 hours point of view. That's only practical. There is nothing stops you from using one dose while doing, or a dose range while doing clonogenic assay, some other dose when you do MTT assay or anything. No, there's nothing like, there's no rationale.
thank you.
Yeah, any other query you people have? So you don't have any query?
So are they all visiting some radiotherapy center now at 4 o'clock?
Yeah, a few of them, not everywhere. We have 20 students with us. But there are a lot of people who are from outside. So there are a lot of students who are from outside, so they are always here and they can ask a question if it is there. I have one more presentation on micronuclei. I'll show it, but I was thinking that if they have some questions, otherwise just loading with the things, it doesn't matter actually.
Yeah, you can probably, how long is that video?
No, we have a presentation also, and video is just 27 minutes, 20.
Nice. Nice.
Should I think I should play that then, otherwise.
Yeah, okay.
Because nobody has anything, so it's better that. That is nothing else but the visibly, like I have shown them clonogenicity and micronuclei. If they have any question, they could have asked. I think micronuclei also have presented them.
Yeah, you can play the video. I'm around. Again.
But that is micronuclei. I have shown them. Should I play again? That was yesterday. I have an agarose gel electrophoresis. Micronuclei, I think, doesn't include any results there. But,
Now, whatever is scheduled or whatever is the requirement, please go ahead.
Schedule was there that they will discuss, but that is the issue. So
maybe they like to watch the video. You can play the video, and if they have questions related to the micronuclei, either the assay or the analysis of the micronuclei data, and what are the different ways of analyzing why and things like that, we can discuss.
We have one agarose gel electrophoresis also, growth kinetics also.
Whatever is the thing, and please go ahead and play, and I will be around and I will keep looking at it. As and when there is a question, I will come in. I'm around here only.
I am first presenting giving a presentation on agarose gel electrophoresis, and then I'll go to the micronuclei. Or if you, sir, you have to go at 4, then I can put first micronuclei. Anyway, so I'm first putting the agarose gel electrophoresis for all of you. And then can you see my screen? It is agarose gel electrophoresis coming.
Yes, ma'am.
Okay.
That's Professor Sibha, and today I'm going to demonstrate agarose gel electrophoresis. So basically, This is a technique which is commonly used in molecular biology, and this technique is basically used for the separation of nucleic acid or for the separations of a molecule like the DNA or RNA based on their size. So why we call gel electrophoresis as a gel electrophoresis? Because in this technique, we are making a gel and applied a electrophoresis. Means a continuous electric current is applied on a gel which will going to separate your molecules based on their size. So in this gel electrophoresis, basically, the gel is of the two types. One is your agarose gel electrophoresis and another is your polyacrylamide gel electrophoresis. So agarose gel electrophoresis have very large pore size. So if you want to isolate or if you want to separate a large size molecule like your nucleic acid, DNA or RNA, then we are going to run agarose gel electrophoresis. And if we compare the polyacrylamide gel electrophoresis with the agarose gel electrophoresis, then in polyacrylamide gel electrophoresis, the pore size of the polyacrylamide gel is small as compared to the agarose gel electrophoresis. So if you want to separate the small size molecule, then we will choose the polyacrylamide gel electrophoresis. So now today I have isolated a DNA from a cancer cell. Now we will run this DNA onto the agarose gel electrophoresis and we'll see is our DNA is visible or we isolate a correct DNA or not. So let's start the process. For the agarose gel electrophoresis, first we want to make a agarose gel. For this, we have to weigh a agarose. Agarose you can directly buy from the market. It is a powdered form, and its gel percentage is totally depends on your size of a sample molecule. Suppose you want to separate a higher molecular weight molecule, then you have to make a lower percentage of the gel. The standard is like if you want to separate a 5 to 10 kb of the molecule, then normally 0.8% is good for resolving those molecules, and 1% is the standard electrophoresis. Like we can make 1% for most of the molecules. So now today also I am going to make 1% agarose gel. For this 1% means I have to weigh 1 gram of agarose gel and dissolve in 100 ml of TAE buffer or the TBE buffer. So TAE is tris-base acetic acid EDTA buffer and TBE is tris-base boric acid EDTA buffer. Basically, tris-base acetic acid or tris-base boric acid both are provided the neutral pH to the solution. Neutral pH of the solution means they will provided the buffering capacity to the buffer, and the EDTA is basically ethylene diamine tetraacetic acid, and it, as we all know, it is a chelating agent, so it will chelate the magnesium ion. Basically, the magnesium ion is acts as the cofactor for the DNA enzyme activation. So if you want to run your DNA, so our first priority should be we have to protect our DNA too from the DNase enzyme. So we will make sure that any magnesium ion will not be present around our DNA. So that's why we are going to use this. We are going to use this EDTA in our solution. So EDTA basically chelates the magnesium ion. Now I am going to weigh 1 gram of agarose. So this is 1 gram of agarose, and I am pouring this 1 gram of agarose in the flask. And now this is the TAE buffer. I had already prepared this TAE buffer. 100 ml of this TAE buffer should be used to mix the 1 gram of agarose. Now I am measuring this 100 ml of this TAE buffer. This is 90 and the 100 ml. Now I am going to mix this TAE with this agarose. mix it properly, but till now it's not a transparent solution. So we have to microwave the solution for 2 minutes so that it gets transparent. So now we have to microwave it for 2 minutes. Now I am putting it in microwave and set the time for 2 minutes. Until it gets transparent, we will wait it. In between, you can take it out and mix it once and again put it in microwave. Now we are getting the clear, transparent solution. Let it be cool for 50 to 60 degrees Celsius. Then we can add our ethidium bromide in it until we will seal the edge of our casting tray. This is the casting tray in which we are going to pour our agarose gel, but its two ends are completely open. So first we will seal both the end of this casting tray with the sellotape. So you can seal properly to make sure that your agarose does not come out when you pour it in the casting tray. So one side seal and seal it also on another side. You can see now your casting tray is completely sealed. Then we have to put a comb for making our well for our sample. Then I am putting a comb in the casting tray. Now your casting tray is completely ready for the gel. But still our gel is too hot, so we have to wait until it will come at 50 to 60 degrees Celsius. Then we'll pour this gel into this casting tray. Once this 52 degrees, once it comes at 52 degrees centigrade, we will add our ethidium bromide dye in it. This ethidium bromide is basically an intercalating agent and which binds with the DNA. by inserting itself between the stacking nitrogenous bases of the DNA. Basically, this ETBR we are going to use because it helps in the visualization of the DNA, because it will bind with the DNA. And when we see our DNA under the UV light, then we will clearly see our DNA. So I am going to put it within the agarose gel. Still it is hot, so until it will come up to 50 degree or 60 degree, then we will going to add this ETBR within the agarose gel. The solution is 10 mg per ml, and I am going to take 1 microliter from this 10 mg per ml for 1% agarose gel. Once it cool down, then we have to mix our ETBR within the gel. So I am taking 1 microliter from 10 mg per ml stock of ETBR.
ये क्या डिस्प्ले कर रहा है?
And mix in agarose gel.
अभी ठीक हो गया?
Ah, I thought there was some email shown on this.
I'm just going back.
Put it within the agarose gel. Still it is hot, so until it will come up to 50 degree or 60 degree, then we will going to add this ETBR within the agarose gel. The solution is 10 mg per ml, and I am going to take 1 microliter from this 10 mg per ml for 1% agarose gel. Once it cool down, then we have to mix our ETBR within the gel. So I am taking 1 microliter from 10 mg per ml stock of ETBR. And mix in agarose gel. Mix it slowly, otherwise it will create a bubble in the gel and it will interfere in your sample. So just mix this ETBR with your agarose gel very slowly, so that it will not create any kind of a bubble in your gel. After it mixed with the gel, then we have to pour our agarose gel within the casting tray very carefully. Now I had poured my agarose gel within the casting tray. It will take approx 20 to 25 minutes for it solidified, and then in between we can prepare our sample. For the sample preparation, I have isolated our DNA from the cancer cells. So this is our DNA which I am going to run on this agarose gel, and I am going to take in one tube 1 microliter from this DNA and also 1 microliter loading dye, and in another tube 2 microliter of this DNA and 1 microliter loading dye. Before making the sample, just mark the tube very clearly so that you can identify which concentration is present in which tube. So I am marking with 1, in which I am going to put 1 microliter from the cancer DNA, and the another tube is tube number 2, in which I am going to put 2 microliter from the cancer DNA, so that we can clearly see a difference in the concentration. Now I am mixing it. First, taking 1 microliter from this cancer cell DNA. Putting in 1 marked tube. Then taking 2 microliter from that DNA and putting in 2 marked tubes. Now for tracking our sample, we have to also add our DNA loading dye within our sample, so that we can see our sample clearly within the gel. So this is the DNA loading dye. I am going to take 1 microliter from this loading dye 5x and putting in 1 microliter of the DNA, and also 1 microliter from this dye and putting in 2 microliter of this DNA. So I am setting my pipette to 1 microliter. Mixing this dye. Taking 1 microliter from this. Mix in 1 microliter of cancer DNA. You can see our DNA is completely mixed with the DNA loading dye. Same thing we have to repeat with the 2 microliter of the DNA. Take 1 microliter from this loading dye. Mix in 2 microliter of the DNA. Now your sample is prepared. Sometimes some people, they will mix the glycerol also with their samples, because the DNA is lightweighted. So when you pour your DNA sample within the well, sometimes it will come out. So for the proper settlement of your sample, some people mix the glycerol with their samples, but I am only mixing a loading dye. Now this is still takes time for the gel is solidified, it will look like this. It will look like this once your gel is solidified. So after solidification, first you have to remove the comb so that your wells is properly visible or properly formed. So I am putting this in the electrophoresis unit. So this is the electrophoresis unit, and I am putting my agarose gel within the electrophoresis unit. Now we have to connect our electrophoresis unit with the voltage meter. The negative end should be connected with this negative or black marked LED, and the positive or the red one is connected with this positive and mark. Once you load your sample within the gel, you have to be very careful, and you will make sure that your well should be towards the negative end. Because of the presence of the phosphate in your DNA, the DNA will contain a negative charge, and this is also the negative. So negative repel each other. If you are putting like this positive one is with this negative end, and this negative end with this positive one, then your sample will come out from the gel. So we will make sure that this red should be connected with this red LED, and this black should be connected with this black LED. And here also this red wire should be connected with this red end, and this black should be connected with this black end, so that your negatively charged DNA will attract towards this positively charged end. You have prepared your agarose gel, then we have to load our sample within the gel. Before loading, I am going to explain. This is the 1 kb ladder which we are going to use as a known standard for our DNA sample. This ladder is 1 kb ladder, and I am going to load it in one well, and 2 well is occupied with our 2 samples, so that after running of the gel, we will see what is the size of our sample with comparison with this 1 kb ladder. So now I am going to load my sample with this gel. So this is the 1 microliter, in which we are taking 1 microliter from the cancer cell and mixing with 1 microliter of loading dye. So I am going to load my sample. I am going to load it in the 3rd well. Another one in which we want to check the higher concentration of this DNA. So we are taking 2 microliter from the cancer cell DNA. So this is 2nd one. Mix it one, and then load it in your sample, in your gel. Now I am going to load this 1 kb known DNA ladder. You can load it approx 3 microliter, 4 microliter, if this is enough. I am going to load it 2.5 microliter. After pouring your sample within the gel, you can close the lid. This electrophoresis unit is attached with this voltage meter. Then we can switch it our power and we'll set it at 100. You can run this agarose between 80 volt to 150 volt. Now you can see clearly the bubbles is formed within our tray, so that our gel is starting running. Now it will run from negative to positive. Negative charges on the DNA and negative is this, and so negative repel each other, so DNA attract towards the positive charge. So it will take approx 45 to 60 minutes for the complete running. Then we can visualize this under UV light. So very less intensity of UV light we are going to use for its visualization, because we have to protect our DNA too. So we are going to use very less intensity of the UV light. So this is all about the agarose gel electrophoresis. So after running the gel for approx 45 to 60 minutes, then we can check the length of our fragment DNA, and we can compare the length of our fragment DNA with the known ladder that we have loaded before. So our ladder is 1 kb ladder. So these are the fragments of this ladder. The lower one is the 250 base pair and the upper one is the 10,000 base pair. So now we can check our DNA, our length of the DNA fragment with compare with this ladder. So first, what we can do, we can wipe the screen of this UV transilluminator with the wash bottle. Clean it properly. After cleaning, we have to switch off the light so that we can visualize our sample clearly. Now we put this gel onto this UV transilluminator. Cover this with this cover and switch on the light. Now you can see this is the 1 kb ladder, and in first well we had loaded 1 microliter from the cancer cell DNA, and in second we loaded 2 microliter from the cancer cell DNA, and you can check 1, 2, 3, 4 approach the size of your sample is approach 5,000 base pair long. So in this way you can compare your sample with the ladder, and also you use this technique for the separation of the different kind of the molecules like the nucleic acid, like DNA or the RNA. So you can focus on this gel, and you can see that with the help of this known ladder, 1 kb ladder, you are able to find out the length of your DNA fragment which you wanted to check. So from this ladder, we are able to know the length of our DNA fragment which is isolated from the cancer cell is approx 5,000 base pair. So this is the whole process of agarose gel electrophoresis. So I had explained each and everything regarding the agarose gel electrophoresis. So this is a commonly technique used for the separation of the molecules, mainly the nucleic acid. Thank you.
So there were some mistakes which Komal has explained to you. She has tried to make it understand you the methods, but there were some places she was speaking cell and something. So it was like, and we could not do the editing of the video there, but the only thing she has tried to tell you that how to do a gel electrophoresis, agarose gel electrophoresis, because SDS page we have already told you. and she has brought the cancer cell DNA in between, because she was trying to think that because it is a radiation related course, so she tried to show you something related to the cancer cell. Means she was trying to the whole genomic DNA of the cell. So there were certain say mistakes in the sentences forming and somewhere, but the technique was completely correct what she has presented, and her total the method was also correct which she has given you. And so if you have any query, if you will ask me some questions, then I will explain it. Otherwise it will be difficult for me to understand that what you really want to understand. So if you tell me what you want to know, that would be better for you. How many of you really understand I think all of you are the biology student. DNA ladder, do you really understand what she was trying to show you? 1 kb when she said. So what does it mean? Did you understand it? Okay, so if it is like totally non-interactive, so it will become difficult for me to train you people. But say we have to use some kind of a specific ladder where you have to purchase these kind of ladders. Earlier when we used to do PhD, we used to make ladder in our own laboratory. We used to take the different sizes of the DNA, mix them in a right quantity, and we used to run it. But now you can purchase the standard DNA ladder, which starts from a certain base pair strength and that goes to the higher base pair. So that is why she was saying it was, and it is known as a 1 kb. You can buy it from the different companies. So that she has run as a marker, and in the side of on the side of the other in the other well, she has loaded the other DNAs in order to show you. And by matching the movement of the DNA, you can match that the which particular band it is matching with the ladder. You can specify that this is the size of your isolated DNA. So so if you have any more query, you people can tell us about it. And otherwise, is there anybody who wants to ask anything?
Chaka?
No?
Oh, sorry. No. Charger. No, we'll plug it. No, it's okay.
So is there any other query from any one of you?
Yeah. No problem. Don't worry about it. Yes.
So, okay. There is a very small, if there is no discussion, then it's fine. I have a very 3-4 slides on one of the, and I have made it purposely very small because, yes, even if it is a basic query, you can ask it. There's nothing, we are sitting here to train you, so you should not feel ashamed if you have any small query, you can ask it. Prachi Mishra.
Yes, ma'am. So I wanted to ask, like she was demonstrating right now for agarose gel electrophoresis. So I've also done SDS page, but for very less time. I have since I am a pharmacology person, so I've been mainly dealing with the preclinical studies. But I've got very less like acquaintance towards this. So there is a concept of loading dye and a tracking dye. Like she added ETBR and also she added another dye. So I wanted to know the difference and why do you add it, and like what is the difference between the two? So I'm sorry, it is might be very basic, but
Yeah, so it was, I don't think she added 2 dyes, but if she has added 2 dyes, say loading dye and tracking dye, I don't.
Yeah, why two? Basically, she added ETBR.
Added ETBR.
Yeah.
DNA intercalator.
Intercalating yeah.
Intercalates with the DNA. So you can, for the visualization of the DNA, she has added ETBR.
ETBR.
And ETBR will intercalate, and it is a UV positive dye, and when you put the UV light on it, then it
fluorescence shows. Yeah, but then she also added something else in between, like at the end it was a ladder, but before ladder she also added some, that part I couldn't understand, some blue colored.
She would have added the tracking dye in the gel electrophoresis, but if she has added, because she is not here with me.
Okay.
So tracking dyes are added for several reasons, but one of the reason is that you have to track that the gel has been run how long. So by that you have a kind of a estimate that because there is if the tracking dyes have come out of the gel, so you can understand that the gel has been run for a very long time. So from there you are able to track that how much your gel must have run. So for that we put the tracking dye. I don't know whether in agarose gel also she has added, because we generally do not add it. But if she had added, maybe she would have added, but it was just to track the gel. What is the name of that the dye?
Ma'am, in gel, I was adding the ETBR, and in the sample for tracking of the DNA within the gel, I was adding the DNA loading dye in the sample, not in the gel.
Okay, and which dye you have added?
That was bromophenol blue.
Bromophenol blue. Yeah. So what?
Tell why you have added bromophenol blue. I know it, but it's better you tell me.
Yeah, it's just so that so that when you are running your sample, you should know the position of your sample within the gel. So this is the only reason why we are using this loading dye or the DNA loading dye within the sample, so that you can track your sample within the gel.
Okay.
Okay. Now the any other question? Did you understand it or not? Did you understand it, Prachi Mishra? Because see, you have to understand that if you are having a bigger size of DNA, it's fine. But sometimes we run very small DNA also there, and you don't know that how fast it will come out. So if you are doing it, if you have a tracking dye, if you have a DNA loading dye, chances of losing your DNA moving outside of the gel will be minimum. Otherwise, you have to switch off in between and to track it, which is not possible, because once you switch off, you take out from there, you visualize it on this what you call a transilluminator, and then you put it back. That is not a correct way of doing it, because then your gel will get disturbed. So that is a way to track it, and most of the gels we add it. Okay. Any other question by anybody? So we have one presentation, Dr. Amandeep. So Amandeep has an interesting question. I think she's asking from you, sir. Dear ma'am, I want to know reason for immortality of the cancer cell. Is it only telomerase activity or any other concept? Dr. Raghunath, you can answer this.
The immortality is not predominantly, but to a very large extent linked to the telomerase being maintained, but their ability to grow without too much of a supportive stimulation comes from alterations in many of the signaling concomitant to the malignant transformation. Amandeep, I thought from NII?
No, she's here only, but she was probably PhD in NII.
Oh,
Is a postdoc here with Dr. Anand Rangnathan.
oh, okay. Oh, okay.
So, but she probably did PhD from. Where did you do PhD, Amandeep?
From Lucknow, CSIR lab.
Oh,
Yes.
okay. There is another Amandeep in NI, I know.
No. I was thinking this is a girl. Amandeep Chawla was a ACPR MSc, and then later did PhD with, I think, Satyajit Rath's lab, I guess.
Okay. Amandeep Chawla, maybe later, I don't remember. Okay. Yes. So, fine. Any other question by anybody?
Yes, ma'am. I want to ask one question from sir.
Yeah.
Sir, actually, you had told about the 2DG. So, although there are already a lot of clinical data supporting the safety and tolerability of this 2DG, but I wanted to ask that is this 2DG has the drug-like properties or not? Because somewhere I have read because 2DG is rapidly metabolized and it fails to reach the necessary concentration level in the tissues and the organ. So we can say that it has the drug-like property or it lacks the drug-like properties.
It doesn't lag. What is the property of a drug? Is there any single property of a drug?
Like that that I had only read that this is because 2DG.
When we ask a question, what is the veracity of that statement? It's drug-like or not? What is the property of a drug? I'm telling you, answer to my own question. That's a very vague question.
Like it is
not a scientific question. What do we mean by a drug-like property? Right now, let's come back and discuss. Yes, it is uptaken because it's like any sugar molecule. If you eat anything, or if you get injected, all your cells which have receptors for glucose will take it up. Similarly, they will take up 2DG as well. Now, and therefore, from that perspective, irrespective of the location of the tumor within the organism, the human, it will certainly reach like glucose would reach. And therefore, to say that to administer 2DG would not reach the tumor site, and before that it's all metabolized and gone, is a false statement. Now, second, because it is consumed by various cells, taken up, consumed, metabolized. However, 2DG per se is not metabolized readily after it is phosphorylated to 6-phosphate. In other words, unlike glucose 6-phosphate, it goes down the glycolytic chain to pyruvate and then converted to lactate under anaerobic conditions and enters mitochondria under aerobic conditions through the Krebs cycle. 2DG6P stops getting into the glycolysis cycle soon after conversion from glucose to glucose 6-phosphate.
Yes,
that's when glycolytic block occurs. However, the fate of that trapped 2DG6-phosphate is dependent on the phosphatase inside and so on and so forth. That's something that we'll discuss. Now, because it is taken up by all cells, of course, in a glucose transporter level dependent manner, the level in the blood where it was introduced either by intravenously or when taken orally or any route, it stays for shorter interval of time. In other words, the levels keep dropping in the blood at a rate of 50% every about an hour and a half. The T half, what we call as the half-life of 2DG in the blood is only 90 minutes. In other words, if you gave somebody 2DG now, saw that the level picked up and reached here, every 90 minutes, the level will fall by half. So in about 6 to 9 hours, it would have gone through 4 or 5, 6 half-lives, and the level becomes by, let's say, 10, 12 hours, right? So it does have an effect like any other drug. But as you know, the half-lives of different drugs, depending upon the nature of the drug and their interaction with the target, are very different. And therefore, to make very gross statement that it's not like a drug or it's like a drug is probably have less meaning. Yeah.
Okay, sir. Thank you, sir.
Yeah. No problem. Now,
I will just
all those who watched, oh sorry, there is a lot of noise that I have no control on that. All those who watched the Agross electrophoresis demo video, I have a question. Why was she focusing on this so-called ladder of the ladder height being about 100 base pairs? And what is the size of the genomic DNA? And why was it Komal who was showing? Why she was showing for a DNA size of 100? Is it really meaningful? Why was she showing? Did anyone ask? Nobody asked the question. What is the rationale in doing a gel electrophoresis with the focus of around few hundred base pairs with ladders from 100, let's say down, ladders up to 1000, 100, 200, blah, 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 up to 1000. And what is the size of the genomic DNA? It's million times more than 100, right? So what's the use? Why should one worry about Agross gel electrophoresis? In other words, what is the utility of Agross gel electrophoresis in any of the things that we have been discussing so far? Nobody asked a question. Why is this useful? Why are you discussing this? An electrophoresis which resolves DNA in the size range of 100 to few hundreds or many hundreds. What is its usefulness? And I guess all of you know its usefulness. I want to know what is the usefulness. Can anyone answer? Maybe Komal will clarify for you as to why she was discussing Agross gel electrophoresis. Where is the application of Agross gel electrophoresis, Komal?
Komal,
Yes.
अपना वीडियो ऑन करो.
Yes, sir.
Yes. So where do we use this Agross gel electrophoresis that can resolve few hundred base pairs, 100 to many hundreds? What is the utility?
Sir, I think when we isolate our DNA or the RNA, so we should also know what is the length of our band. So
his question is not this, Komal. He is asking. You again ask her. Maybe she.
Where do you use Agross gel electrophoresis that you described, where you said the reference marker is 100 base pair ladder going from, let's say, 100 up to 1000 or 1200. Different companies give you up. Some give up to 1200, some up to 1400. In any case, only
sir,
up to 1000 base.
Sir,
where do you use this in your work? Did you use any time?
Sir, till now, not, because I am also
All
a
right.
first year
Doesn't
student.
matter.
But sir, I wanted to add something. Just if we want to do some cloning, so we should also know the size of our insert. So I think it's one of the application of the Agross gel electrophoresis.
Good enough. Good enough. That is one. First and the foremost thing, Agross gel electrophoresis, the one-dimensional, again I repeat, Agross gel electrophoresis, the ability for you to resolve is only up to many hundred base pairs, 1000, 1001, right? Your genomic DNA, as I said, is orders of magnitude higher. So if you isolate your DNA from the cells and load it and run,
yes, sir,
believe me, you'll get nothing except a fluorescent band at the place where you loaded. Let's be very clear about. So your Agross electrophoresis will be of little value, but still we use this. So the context, the question I am asking is, what are the contexts that this will be used? Let's say you have not yet done, but if you did this, did you ask yourself a question? Why should we be doing this? Where are we going to use? Or did you ask yourself a question? Hey, where am I going to use this gross gel electrophoresis? One, you said when you work with some constructs and inserts, or even PCR product, or so, fine, fair enough. What else? And why that so-called base ladder, the base pair ladder in and around 100? Not you. Anyone else out of the 27 can answer, who are all participants. I'm sure some of them would have encountered or used or known. Right?
Sir, also I think we want to check that we are getting the single band or the multiple band. If like I have to perform the RT-PCR or the other technique, so if I wanted to check the purity of our PCR product, so we can check also that our designing of the primer is right or not. If we are targeting some particular portion of our
primer.
No, not for the primer,
product.
For the gene which we are targeting. The gene product of our interest, right?
For the PCR product.
Yes.
Okay, fair enough. Then.
So with this also we are able to know the specificity or the non-specific band we are getting or not.
I have no need for doing any PCR product quality control or check. So I don't need that. Will this be useful anywhere else in the type of work that you people are doing, and some of the lectures that you heard, things that are involved? Anywhere else that came to your mind? Anyone else?
DNA damage कुछ याद आया?
During apoptosis, the cleavage of the nucleus, the cleavage of the nuclear DNA happens at the internucleosomal region. That's the classical DNA damage, not the radiation induced, but as a part of the response. During apoptosis, at the end, the nucleus which is activated cleaves the DNA at the internucleosomal region, as also at much higher level. That cannot be resolved by single direction gel electrophoresis, but the ones that is cleaved at the internucleosomal region will generate pieces which is equal to the length of the DNA between two nucleosomes, and also the length of the nucleosome, which is around 100 and odd, up to 120. That's where it is extensively used. Of course, not all apoptotic DNA fragmentation will result in the generation of this fragment size, as I said. But where it is, this is going to be very useful. Yeah, in analyzing the apoptotic DNA degradation.
The gel electrophoresis is also used very largely for the DNA fingerprint. So it is, I'm talking one thing where it is commercially also used. So DNA fingerprinting is also one area where it is become very important, and it has a very important role in the say some of the criminal cases, and even in the research also there. So gel electrophoresis, and in relevant of radiation, what Professor Dwarkanath is saying, that to find out the fragments of the DNA and what kind of a fragmentation is done, that also can be found out from there. If you go into the larger sequencing gels are there, or larger gels are there, then you can even find out that also, that what kind of fragments have been generated. So that is the major use of DNA gel electrophoresis.
Due to paucity of time, many things which are actually very core, central to radiation biology, we could not discuss for paucity of time, because we have a broad topic. But one area where, one technique that is related to electrophoresis, which in the past at least has been extensively used for assessing DNA strand breaks, is two-dimensional gel electrophoresis called the pulse field gel electrophoresis. There are different variations of pulse field gel electrophoresis. In a single field, unifield gel electrophoresis, as I said, you cannot resolve this long sizes of DNA, the genomic DNA. And even if there are breaks, you will not be able to resolve. However, if you run the electrophoresis in one direction, clamp it and change the direction at a certain angle, go like this and change the angle, again go like this, change the angle. If you did this, it's called the pulse field. You give pulses of the electrical field, then you can resolve long stretches of DNA. That technique has been extensively used in assessing the DNA double-strand breaks. A lot of work was initially done with the yeast DNA, because we know the total length and the number of fragments that we get reproducibly, and it has also been used to a certain extent in assessing the radiation-induced DNA double-strand break in mammalian cells. Yeah, there's a vast field. You can read all this. This is all available on the internet. But that's not single field gel electrophoresis using the agarose gel as you discussed. Of course, they're all in agarose, but pulsatile field. All right, if there are not much.
Yeah, so there is one, yeah, if you have, sir, any other thing you can move, but.
No, I'm absolutely fine so far as the course is concerned. If you permit me, then I'll log off.
No, it's okay, but there is one small presentation that is on growth kinetics.
Oh, okay.
But it is a very small one. Because I'm just putting it here. I have to share my screen. You have to give me 2 minutes actually. I have to.
How long is it?
It's 4 or 5 slides.
Oh, okay. Then I'll certainly take a look at it.
So just give me 2 minutes.
Sure. Please.
Just So can you see my slides? Is it visible?
Yes,
It says cell growth kinetic assay. I can see that. Yeah.
Yeah. So it's a very first of all, why do you need the growth kinetics? Fine. So I although explained it yesterday again a little bit, but I would like to read it from here so that you understand it. Population growth rates are a core property of a cell lines and can be influenced by many factors. So if you want to see the effect of any substance on the cells, and cells when we talk here, please understand more or less in all this say radiation biology course, we have been talking more or less with the mammalian cells. So we are not taking in the reference bacteria very often in this whole course, because we were talking about the radiation effect on the mammalian cells most of the time. So here also, more or less, whether it is a bacterial growth kinetics or the mammalian growth kinetics, they have difference to each other, but both of them have a tendency of a growth. So as such, in controlled experiments, cell growth rates, that is how quickly the population size changes over time, may correlate with the presence of drugs or toxins, temperatures, or particular genetic changes in the cells, and other factors which may be radiation also. The cell growth rate is an especially useful variable to feed into models of how a culture will progress. So if you are, because we use cell culture, mammalian cell culture, as a model to do this study. So most of the time we are doing study on the basis of mammalian cell cultures. And because whatever effect, whatever assays we do, we try to do on the basis of, so if we don't understand the mammalian cell culture properly, we cannot say, so that is why it is a kind of a model. So one thing which we teach also, that the animal model, cells as a model, in cell biology classes we teach it, that you should have a proper model. And so here cell culture is your model. And if you don't understand your cell, if you don't understand your cell culture, you cannot, if your model is not correct, then your whatever inference you want to take out of it, you will not be able to take it out. So whereas well-established mathematical definitions of the growth rate exist, it is not obvious how to estimate the growth rate from measurement of cell culture. Suspension cells follow logistic growth to a decent approximation, and in that case, growth rate could be derived via some form of the logistic fitting. So just a minute.
Sure.
Hello. Oh. Wait, just a minute. आज 31st March है, there is some. I'm extremely sorry. We have to do some billing and it needs my sign only. So now every OTP comes to me, gem purchase and everything. So suspension cells follow logistic growth to a decent approximation. And in that case, growth rate could be derived via some form of the logistic fitting. I'll talk to you about that. The most common measurement for cell growth rate is the so-called population doubling time. That is the time it takes for a population to double its size. So if you have seeded certain number of the cells, then in how much time it will get doubled, that is called as the doubling time. And that varies between the cells. And let me tell you, even the cell lines which we use in our laboratory, sometimes they become either contaminated or they become so much say gene variation occurs in those cell lines after so many of the passages that it actually changes. It's even the doubling time also changes for those cell lines in a huge manner. So one should not work on such kind of a cells which are not matching with the parental cell line, which from where you have bought it or somebody has gifted you. So one has to look into the literature and one should always look into the morphology and the doubling time of the cell line before doing any experiment with any cells. And nowadays, most of the journals, they say that you have to do the characterization of the cell line every 6 months. And that is, you have to do a proper genotypic characterization of the cell lines, and then you can say that this is the same cell line. Otherwise, people don't believe in such kind of a cell lines which are being used in the laboratory from very long time. So the doubling time can be estimated from the population size at 2 points for cell growing exponentially. This value is well defined. Hematocytometer is I think this all of you must be knowing. Counting with some vital stains is the most common method, as it requires only a very minimal sample of the very less number of the cell and very small amount, 5 to 10 microliter, for monitoring a culture. So you put your cells in the hemocytometer and you count it, and there are chambers are made in the hemocytometer, and by the distribution of the cells in those chambers, you are able to count it. For most of the presentation which was shown to you were shown you with the some kind of a kind of a cell counter, which was actually an automatic cell counters. But hemocytometers are the most simplest one, and we use it in our laboratory, and most of the people use it in their laboratory. Owing to its low cost and its availability, hemocytometry counting has become the de facto standard in many applications. That, coupled with being measurable without significantly affecting an ongoing culture, makes it a prime choice for estimating the population growth rate. So here I'm showing you one small molecule which we have. We did some work with this molecule in last 4 or 5 years, and this is a drug which is used, which is a standard drug and used. You have to again, it will come. He's not here. I'm asking to write here. हाँ बताइए Okay, bye. चलो हो गया. I'm online. So when it is so I'm talking about one particular molecule which is a antipsychotic molecule, and we have tried to repurpose this molecule as a radiosensitizer. So you have heard a lot about radiosensitizers, so I'm not going to talk about it. So prochlorperazine is a phenothiazine antipsychotic medicine that is used to treat anxiety or schizophrenia. So we have done some work, we had some results, and we are trying to summarize it here. For example, I have used cell line HeLa cell, and this is a cervix cancer cell line. Then we have used a cell culture hood, that is the BSL-2 laboratory, biosafety laboratory 2, biosafety level 2 laboratory. Then we have used certain culture media, phosphate buffer, trypsin, trypin blue, hemocytometer. And what we have done, that we have washed it with the phosphate buffer saline, trypsinized this. You have heard all these things from there. And when we have grown it in the dish, and it was 70% confident, it looks like this under the microscope. And now what we will do, that after seeding the cells, cell counting were done, and the cells were seeded in 35 mm Petri dishes at a seeding density of 0.5 into 10 to the power 5 cells in 2 ml of culture. Overnight incubation CO2 incubator to adhere the cells to surface of Petri dish. Next day treatment of cells with drug was done with drug, radiation, drug plus radiation, and then counting the cells at different time intervals were done. So we have done the cell proliferation kinetics. You can do, so we have done the cell proliferation kinetics at 24 hours, 48 hours, and 72 hours. See, this is the standard way to do it. You can change these hours also, but in generally people do it at 24, 48, and 72 hours post irradiation for understanding the effect of prochlorperazine on the growth kinetics of HeLa cells. So there was, so this was only when we have viewed the prochlorperazine. So there was 73.8%, 84.7%, 92.6% growth in the PCZ only treated HeLa cells were observed at 24 hours, 48 hours, and 72 hours post irradiation as compared to the control cells. So there are some numbers are given here. I think it doesn't have any use. Rather, I'll show you here. So if you look at that, so what has happened that we did one experiment. So before going this, I should have had one slide where I should have shown you that normally you have to calculate the doubling time. So if I don't do any treatment and I just run the control cells and we check out, we seed the cells, and after every few hours, if we have to seed it in the different petri dishes, and after every few hours you have to trypsinize and check the cell number of the cells in the hemocytometer, and by that you will come to know that no doubling time of this cell, HeLa cell, is 21 hour or 22 hour or 23 hour. So by that you will understand that when there is no treatment is given to the cells, then it will double in a certain hours. Now, when you know by the standard experiment that it will double in certain hours, then when you will do it same experiment under that certain treatment, under treatment of with some drug, another treatment of certain radiation, you will know, you will say that this drug, these cells proliferation is being affected, whether in a positive manner or a negative manner, means its proliferation is being is reduced or its proliferation is increased or there. So in the presence of a particular molecule in the particular there, but in the case of irradiation, more or less the proliferation reduces always. So here a final slide is being shown to you, and I have kept it very simple, although we have published this data in FRBM, you can see it here, but maybe this data is not there, I don't remember. But I just kept it very simple for you, that you can see here that when the control cells are growing in a very, and you can see the curve also, even the shape of the curve in the control is different as compared to the when you have treated it with the prochlorperazine, or you have irradiated the cells, or you have first treated with the prochlorperazine and then irradiated the cells. So in all those cases, the experiments were done, and different cells were plated. And as I told you earlier, that you have to use biological replicates and technical replicates in the case of any experiment. If you do, whether you do chemistry, you do biology, you should have technical replicates, you should repeat the experiments, and then you should reach to any conclusion. So what we try to show over here to you, that when you use the PCZ and radiation together, there is a severe effect on the proliferation kinetics of the HeLa cells, which suggests that PCZ or radiation is not allowing the cells to divide, to replicate, to rather I should only say divide, and it is one or other way affecting the proliferation of the HeLa cells. And you have heard a lot from very a galaxy of speakers that there are number of proliferation markers are there. There are number of about the cell cycle also. You have heard about the ATM, ATR, which are being recruited at the site of the radiation. Lot of things have been informed you by the other people, but that is after the proliferation assay, when you go down and try to see what is happening and why proliferation is being affected. That is the beyond this, and this is one of the basic experiment which a student, when it comes, whether he is working or he or she is working on a radiation or drug, that is a different thing. When you are in a process of learning the mammalian cell culture, these kind of experiments are done in your laboratory, are being being told to you by your supervisor or by your any instructor, so that you can be trained. And you have to see that when you do such experiments, your proliferation kinetics curve should remain same all the time. It should not change. If it is changing, it means you are not able to repeat your experiments. Please forget about these three which are there, but you at least think about the control one, because maybe all of you may not be doing irradiation in your laboratory. So this is one of the best way to check that your cell line is behaving in a proper manner, your cell line is not contaminated, your cell line is the same cell line which you are claiming. So this is one of the way. After looking at the morphology, you have to look at the morphology of the cell. Then you have to do the cell proliferation assay for in that case. I would say that if Professor Dwarkanath want to add something, or maybe I have not told it properly, he can add.
No. Maybe just a few additions. What Dr. Vibha is trying to show and elaborate here is the consequences of irradiating a cell are several things. One, as the end consequence, one is loss of clonogenic potential, that is assayed using the colony forming ability. The other effect is radiation-induced growth inhibition. Radiation compromises the ability of cells to proliferate. It has two components. The growth curve that she has shown, which is on the screen, the pattern is contributed by two phenomena. One is the cell death. Radiation at each of these doses can cause some amount of cell death, and also causes an inhibition in the progression of cells through the cell cycle. That means it retards the progression of cells through the cell cycle. Both these put together will result in less number of cells seen at any post-irradiation time as compared to unirradiated cells, which is very evident here. You look at the green and look at the blue. We are right now discussing or comparing only unirradiated cells to irradiated cells. At every given time, 24-48 hours, the cell numbers in the irradiated group is less than the control. This is contributed by two phenomena: radiation-induced death. The other one is radiation-induced perturbation in the progression through the cell cycle. Now, if the cells did not proliferate at all, then this curve would have stayed almost parallel to x-axis, which doesn't happen. Initially, the slope is very shallow. The green, initially it is shallow, and then on it picks up. If you actually see beyond 48 hours, it is almost parallel to the blue, suggesting once the cells overcome the perturbed cell cycle, they grow in a way similar to the unirradiated cells. In other words, radiation cannot change the cell cycle time. It only changes the population doubling. What population doubling is, there were n number of cells, now there is 2n. If some cells of n decides not to proliferate, to reach 2n, it will take more than the cell cycle time. If all cells are in the cell cycle, then the population doubling time is equal to cell cycle time. If some cells do not take part in the proliferation, the population doubling time is larger than the cell cycle time. Cell cycle time is the time between two mitoses. Population doubling time is the time taken for n number of cells to become 2n. N becoming 2n has two components, as I said. If some cells die or decides not to proliferate and then moves through the cell cycle slowly, then at any given time the cell number will be less. You can derive all this information from the simple growth curve. However, it is probably appropriate, if Dr. Vibha will permit me to make this comment or suggestion or observation. Yes. It's not a great idea to report growth inhibition at different time intervals.
Yes, sure.
The classical way of showing or inferring on radiation-induced growth inhibition is after a given time, either 48 hours or 72 hours, what is the relative growth that is obtained by cell number ratio at any given time divided by the initial cell number. We call it NT by N0. NT is the number of cells at any given post-radiation time divided by N0. That's one value for control. And you get the same NT by N0 for the radiation. Now, if you divide NT by N0 for the radiation by the NT by N0 for control, it will give you the extent of inhibition. That would be a prudent way of inferring the radiation-induced growth inhibition. What is interesting in this is this radiation-induced growth inhibition was accentuated by the prochloropressin in this set of experiments, suggesting that this drug did not help the cell overcome. In fact, it accentuated the effects of radiation. And one can ask a question, because the drug also had a marginal effect. Does this will let you derive more information? Was the effect of radiation and prochloropressin additive in nature, more than additive in nature, subadditive? All these things are derivable information. Yeah, I'm done.
Yeah, so yeah, very nicely. I think the portions which I have left or I did not make it clear. So it's really nice what Professor Dwarkanath have added. And yeah, so I think now it is time to say goodbye. For all of you, still experiments with the Ayurveda biology and other 20 students are still working, and I came to know that they will be back by 5. So I cannot, I don't want to run it further. I would say that I would like to just thank all my speakers, chairpersons, and say, not because that Professor Dwarkanath is here, so I'm saying it. I can really tell you that I could run this program because we had a several round of discussion with him that how to run it. And still there are many things which we have learned from this program. If any one of you want to give us a suggestion that what was wrong and what was good and what was bad, and believe me, if you will say me that there were so many things wrong, we will improve upon it. We will not feel it bad. And so you can always give us a suggestion that where were we wrong. And I tried my best with the help of other people, whether it was Dr. Rath, whether it was say Dr. Anil Mishra or Professor Dwarkanath. They all helped us a lot, and not only that, in one call they agreed to participate it, they actually helped me to provide the specific speakers from the specific area. We did not try to cover the area which was not in which we do not specialize. So we tried to bring the area, and I also tried to bring here the chairpersons also from the radiation side, so that you can have exposure and you can understand that how much research in the area of radiation is going on all over the country. And you had 2 presentations or 2 discussion sessions with the 2 of the international speakers also, and they also told you, and specifically whether it was Pataji Prasanna or it was Dr. Vikram Bhadrasen, you can understand that they also said that it is a student who have to come out some solutions in terms of the side effects or whatever are the effects of the radiotherapy. If you remember, Dr. Vikram said very clearly that we are stuck somewhere and we need the initiative from the students that they should take part in this area. And I would like to thank all of you. Once again, I would really believe me, even if my own students want to say something, they can say. And one thing before moving anywhere, I would like to say, we have conducted 16 lectures. We have conducted around 6 to 7, tutorials. We have run around 5 videos, and we have run, and I could do everything just because of my students, my PhD students who have really did not do anything from last 15 days. They were just preparing for these GIAN program. And I want to thank all of them. And I will take a few names. They will say, no, no, ma'am, you have not taken my name. So for me, still I will take the name Palak, Antra, or Hungyo or Komal, and the students who have not using the radiation like Komal, they have also shown a lot of keen interest. They have participated and preparing a video, speaking in front of a camera for the first time, and showing your skills very first time, because they were not given any time for the preparation. I messaged them in the midnight, and the photographer and the videographer was there. So with all these things, Tausif, Savio, Pragya who was there for almost for 5 days, from beginning to some morning to evening. Whole GNU CIS who has really Vivek, Abhinav, Rishabh, who have day and night tried to run the net, and they put their whole say energy, and they have written to NKN for the non-stop say internet capacity, and they were every day there by 9 o'clock, and they left at 6 o'clock. So I would like to really thank all of them with my heart. And if I have left anybody, I would like to say Vaishnavi also, Vaishnavi, who has just joined the lab, has been writing to the people about it. So with all these things, I would like to thank all of you. And I want, if any one of you want to give any comment on this course, you can give it. Dr. S.K. Mishra is there, or any faculty from outside. If you want to say that we should have included this, any one of you can give a comment.
Okay. All right. If you will.
Just unmute him. I muted him, I think. Dr.
Yeah.
Just yeah.
So if you will permit me, may I log off? And thanks everybody. And most importantly, thanks Dr. Vibha for a great opportunity. And I think I also learned a lot from interactions and listening to some of the lectures. We will take this forward and then make it a continuous program. If need be, we could come down to GIAN, spend time with students who are more keen, and then extensively take few topics and then expand on it. Thank you very much.
A few comments I would like to share with you, because
yes,
there were about you in my email, and they said it was an excellent talk by you. And they even asked us that I have got an email from somebody yesterday that I forgot the name, that do you run more courses like this? They were asking about you. So there were a lot of compliment about your discussion. So they were asking if we want to attend such more courses, where can we attend?
Thanks for their kind words, but we will endeavor to do it even better so that more and more people find benefit from this. We need a platform. Thank you so much.
Okay, bye bye.
Okay, bye.
Okay. So anybody else wants to say something? Dr. S.K. Mishra is saying excellent program. Amandeep is saying my special thanks to Professor Dwarkanath and Professor Vibha Tandon. And I think before also, thanks to all the organizer and speakers for such a wonderful course on radiation biology. So we have received a certain email also from everybody. So with all these things, Ritesh is saying, thank you, ma'am, for organizing this program. For all of us, congratulations to all the team. So I hope Ritesh and people, at least these students whom I know, that you have been benefited out of this, because at least if you have learned even the 20% or the 30% of the things out of this course, that is enough of this. And you have to realize that you have been taught almost say 60 hours out of this course. And so that was in general, when we run a say course in the semester, it is 40 to 42 hours course. A 3-credit course is almost 46 hours. So you can understand that how much of efforts have gone. And once again, I would like to thank my students, CIS Director, Dr. Sanjeev Kumar, who have really stood with me because I was really afraid the way he has, one day before, he has changed the whole cable which of the internet which was coming to the molecular medicine from the say hub from where the internet comes here, so that we can get a non-stop internet there. So with all these things, and I once again, if there are some mistakes, it is ours, and we will try to improve with all these things. And I would say that all of you have to please register and send your feedback, and because GIAN JNU is saying that you need to register on the website for yourself, and for that I will keep on writing emails. I've received certain emails on the there, and that you will be send your certificates. I am not sure that I'll be able to post it or not. I will try my best to post it, but for posting I will be needing a postal certificate, so I will try to do it the digital one only. And so that I have to discuss with the GIAN committee, because but anyway, everybody will find the certificate, and you will get the certificate within the next 1 week to 10 days, because it has to be signed by 3-4 people. It has to be signed by rector, it has to be signed by me. So if and maybe GIAN JNU coordinator. So it will take time. Keep say some I would say patience with us, and all MSc and pre-PhD students who have joined this course, I think you have learned something. I can see Preeti, Maria, and other students also. So with all these things, with thanks a lot, and I will clap for the students who have prepared the videos, because I would have never expected, even Vikas, I think I left Vikas. So Vikas have also done a wonderful job. And with all these things, Savio, who is participated silently with this, Tausif. So all of us were the part of this say program. And I would say that I don't know about you, but I can only say that I was not expecting it to be that I would be able to do it so nicely. At least I am satisfied. I know that there was something which I could not do, and but next time, for me, it was the first time I ran a GIAN program. I have run other programs in Delhi University's university summer program, and I've run it for 15 days and 3 weeks. But that was a kind of a physical program, and I have hosted around 50 students over there. But that was, I had a whole team of faculties. I was coordinator, but here it was a very different kind of a thing. And with all these things, all the best to all of you. And if anything anybody wants to say, otherwise we will log off. Okay, fine. So I think nobody wants to say anything. So thanks a lot. And JNU CIS is listening or not listening? They are here?
Yes, ma'am.
Not Savio, you, not other people. Vivek and all have left?
Ma'am, they're here.
So Vivek, thank you very much. Abhinav and...
Yes, ma'am.
Welcome, ma'am.
Welcome, ma'am.
Okay, so thank you. And आपको मैंने बिठा के रखा. So, but thanks a lot for your courage and your support. So thank you. Okay, bye-bye.
Okay, ma'am.
Namaskar, ma'am.
Thank you. Bye bye. Please return those laptops. Okay. Bye bye. Fine.